take 10 seconds. Ma'am, we are live in 3, 2, 1. We are live now.
Namaste and a very good morning to all of you. On behalf of the Pune chapter of IADVL, I welcome you all to today's CME, an interdisciplinary approach to polycystic ovaries. Before we begin, I'm happy to share with you all that we have been granted 1 MMC point for the CME, and our observer for today, Dr. Suhas Nene, is here with us. Welcome, sir. Now, allow me to just share my screen in a moment. Now, before we begin, let's keep in mind, and let me remind you to kindly mute all your videos and audios. We will be taking questions via the chat box, and all the questions will be addressed during the panel discussion. A link for the MMC feedback form will be sent on the WhatsApp group. Kindly make sure to fill the form at the end of the CME to be able to avail the MMC point. I now welcome our president, Dr. Dhanashri Bhede ma'am, to give the welcome note. Over to you, ma'am.
Yeah. So can you stop sharing, Purva? Yeah.
Yes.
Thank you, Dr. Purva, and good morning, your friends and colleagues. On behalf of my team, that is Team Pune chapter of IADVL, I welcome you all for today's CME on this very important topic of polycystic ovarian disease and its implications in clinical practice. Now, as a dermatologist, we have a very important role to play in the management of these patients. However, the health implications like infertility, obesity, dyslipidemias, then diabetes, there are so many factors associated with this particular problem, and they have more serious consequences. So as a dermatologist, we should be able to diagnose these patients early, and we also have to have a comprehensive plan for these patients, a roadmap on which these patients can lead their life, because it requires a long-term commitment to the treatment, and it requires a lot of motivation to continue the medicines as well as the lifestyle modifications. So it definitely requires interdisciplinary approach. And keeping this in mind, we have invited colleagues from other subspecialties on this CME today. So we have with us a renowned endocrinologist, Dr. Uday Phadke, and he is going to tell us about how to investigate and optimally use the various anti-androgen therapies in practice. We have with us Dr. Ashwini Margare. She is a gynecologist and infertility specialist, and today she's joined us from Australia. She's there on her fellowship and probably likely to migrate to Australia in next few days, and she will tell us how to optimally use the oral contraceptive pills in these patients. Exercise, nutrition, it is extremely important as far as the lifestyle modification is concerned. We always tell our patients that your lifestyle is not good and you have to change this and change that. But how to exactly go about it, it will be dealt with by Dr. Maitri Bokil. She has an advantage of having a master's degree in nutrition as well as exercise physiology. And then, of course, the dermatologist, you cannot do away with dermatologists while you are managing these patients. And we have with us our two own people, Dr. Vasudha Belgaonkar. She is from BJ Medical College and she's associate professor there. We call her encyclopedia of dermatology. Her knowledge is really vast. And with us, another dermatologist is Dr. Varsha Sidwadkar. Varsha has an advantage because she's not only a dermatologist, but she has done her diploma in nutrition. So she is the right person to guide us about the nutritional management of these patients. So with this brief overview, I hand over the proceedings again to Dr. Purva Shah, and we will begin with our scientific agenda immediately. Thank you so much.
Thank you, ma'am. Moving on to the scientific agenda for today, let me introduce to you our speaker for today.
Purva, please share your screen.
I am. Dr. Ashwini Margare is an infertility specialist and a director at Bliss Women's Clinic in Aund in Pune, a consultant obstetrician and gynecologist for the last 15 years. She has special interest in infertility practice and is working as an IVF consultant at Cloud9. She currently is in the process of relocation to Australia for a fellowship in reproductive medicine and clinical embryology. Ashwini ma'am, I invite you to kindly come and share with us your talk and your screen. Over to you, ma'am.
Good morning, everyone. Just give me a moment to share my screen.
Okay.
Yeah, now I think I'll be able to share. Am I visible? Is my presentation?
Yes.
Yeah.
Yeah.
So
Perfect.
good morning, everyone. I'm Ashwini Margare. Dr. Purva, thank you very much for the kind words. At the outset, I would like to thank Dhanashree Bide Madam and the organizing team for inviting me for this CME and having me here for a very practical topic of prescribing OC pills, which, when, and how long. In this presentation, I will be talking very briefly about actual PCOD symptoms and diagnosis, and I will be mainly presenting the recommendations which are related only to the use of oral contraceptive pills in Indian context. As all of us know, PCOS is a very common reproductive, endocrine, and metabolic disorder characterized by hyperandrogenism, oligoanovulation, and polycystic ovarian morphology, the prevalence of which is around 6 to 8% depending upon the diagnostic criteria used. Though the diagnostic criteria hasn't changed for last 20 years, what still all the official guidelines are recommending is the Rotterdam criteria, which established in 2003. The symptoms of PCOS are varied. Sometimes there is an irregularity of the period, sometimes amenorrhea, weight gain, especially around the waist, excess growth of hair on body and face, persistent acne, usually unresponsive to the conventional treatment, or oily skin, then thinning of scalp hair, difficulty in conception, dark skin patches, skin tags, pelvic pain, mood swings, anxiety, or depression. Patients of PCOD will have many of these symptoms, but all the patients may not show all these symptoms. So it is not a very particular picture at times. You will see a combination of 2 or 3 symptoms at a time. Coming to the oral contraceptive pills have been the first line therapy for concurrent treatment of menstrual irregularity, acne, and hirsutism. So when you want to treat all the 3 in one go, it is an established first line therapy. The association of PCOS with metabolic syndrome brings up the debate regarding the risk versus benefits of oral contraceptive pill use in PCOS women. Moreover, the presence of confounding factors such as obesity, smoking, diabetes, and other cardiometabolic comorbidities is a significant limitation in comparing different OCs as well as the risk and benefits associated with their use. I think that is the main purpose of today's presentation, that we want to assess this risk versus benefit and come to some conclusion when we use the oral contraceptive pills. Now, the basic pharmacology, there are 2 types of oral contraceptive pills, out of which we will be concentrating more today on combined oral contraceptive pills. And there are second type, which is an only progesterone pill. Only progesterone pill is many a times reserved for lactating mothers, and it's mainly for the contraceptive purpose. Combined oral contraceptive pill contain ethinyl estradiol, the dosage of which usually varies between 20 to 50 microgram in various combinations, but the most commonly used is usually between 30 to 35 microgram per tablet. The second content of the contraceptive pill is a progestin, which is a derivative of 19-nor-testosterone. These derivatives are usually northestrone or levonorgestrel, disogestrel, gestodin, and drospirenone. So depending upon the generation of the pill, the content of the progestin is going to change. This diagram explains, it is a self-explanatory about how the oral contraceptive pills act, but for a non-contraceptive use, mainly increase in the SHBG levels and facilitating the metabolic clearance of testosterone, decreasing the free androgen index is the major action when it comes to non-contraceptive use. Why I have mentioned here briefly about the pharmacokinetics is oral contraceptive pills are very, very closely related to various drug interactions. So estradiol, that the reason for which is estradiol undergoes an intensive first pass effect in the cytochrome P453 system of the liver, leading to the formation of its metabolites. So as simple as a tablet like paracetamol or aspirin or any basic antibiotic also has a drug interaction with oral contraceptive pill. And that's why while prescribing a pill, the drug history is going to be very, very important. So when we talk about the combination pill, since 1960, these combinations pill have started and then the various generations have formed. Right now, what commonly we use is the third and fourth generation of the oral contraceptive pill. If you see the combination of ethinyl estradiol and progesterone, the ethinyl estradiol dose is more or less same. The estrogen compound has always been as ethinyl estradiol, but the progesterone component has changed depending upon the estrogenic, the progesterogenic, and the androgenic activity. Now, why the reduction in the dose of estradiol is possible? Because of the availability of the new progesterones with the high anti-gonadotropic activity. So while choosing the right contraceptive pill, we have to look at the combination and the individual action of that estrogen and progesterone. So this is a very common scenario where we think about when to start, when to stop the OC pill. So let me give you a practical suggestion that whenever you are prescribing it for a non-contraceptive purpose, let the lady or the girl start it any day between day 1 to day 5, because that creates a lot of confusion. If the patient is comfortable with day 5, tell her, okay, you start it from day 5 of every cycle or day 1 of every cycle. It is not going to make a difference when it is used for a non-contraceptive purpose. The pill pack is usually of 21 days. So stop the pill after 21 days and restart with the day 1 again. Now, again, restarting it with day 1 is the pill-free interval is usually of 5 days, 6 days, sometimes 7 days. So again, it can lead to the confusion in the mind of the patient. So you just tell her that once you stop the pill, wait for your periods. The day you get the period, start the pill again. Follow-up usually is required after 3 months, mainly for the evaluation of the blood pressure and if there is any other established side effect. And annual visit is recommended considering the blood pressure check, evaluation of the glucose intolerance and lipids if she is a resistant case of PCOS. So before going for the recommendations, we have to look for the contraindications, because contraindications of oral contraceptive pills are something which are scary, and then that makes us think whether to give them for a long term or not. Absolute contraindications are thrombophlebitis, cerebrovascular or coronary artery disease, CA breast, or any other estrogen-dependent neoplasia, undiagnosed abnormal genital bleeding, any known or suspected pregnancy, benign or malignant liver tumor, cholestatic jaundice of pregnancy, hepatic neoplasia, hypersensitivity to oral contraceptive pills if she has used it prior, and of course, any established pregnancy. Relative contraindications are those, it's a list where we say that, okay, you can give the oral contraceptive pill, you can give it safely, but a regular follow-up is going to be required. So the patients who are elderly, who are with diabetes, hypertension, smoking, gallbladder disease, history of gestational cholestasis, history of renal disease, impaired renal function, hyperlipidemia, varicose veins and superficial venous thrombosis, history of migraine, any major surgery with prolonged embolization. So for relative contraindication, when the patient is sitting in front of you, you would have to ask the leading questions, because these things patient might not come forward on themselves. These days, the incidence of smoking and tobacco is increasing even in young girls. So we have to be very cautious when we are prescribing the oral contraceptive pills. So the general counseling before prescribing any pill for PCOD should always aim for maximum benefits and safety. There is a need for counseling about the benefits, risk, contraindications, and alternatives. The important and common side effects for with all the pills are minimal weight gain, nausea, breakthrough bleeding, decreased libido, and drug interactions. Out of which, breakthrough bleeding and decreased libido is something which needs additional counseling, because the moment patient start experiencing this, she is going to give you a call in panic, in a panic situation, that why I'm bleeding in between. So these are the side effects which are going to require a good counseling. When you prescribe any pill, before that, see the age of the patient, any past and present medical condition, any drug use, any history of migraine, cardiovascular risk factors like smoking, obesity or hypertension, diabetes, dyslipidemia, any history suggestive of thrombophilia, history about the use of tobacco and smoking. Physical examination is important. Blood pressure measurement and recording of the blood pressure in your case sheet is extremely important. Body mass index recording is important. Waist circumference, if possible, it is better to check. And pelvic examination and breast examination is not mandatory, but it is always better to have a look at breast examination, because any adenoma you find in the breast, any suspicious swelling you find in the breast, you shouldn't be prescribing the oral contraceptive pill immediately. So what recommendations and guidelines we are looking at is National PCOS Working Group has provided a consensus recommendation on the use of OC pills for PCOS in India. So they were provided by keeping in mind the phenotype of Indian women who tend to have higher risk of metabolic syndrome and insulin resistance. So the recommendations which I'm presenting, these are by the published literature which were retrieved through the searches of Medline and the Cochrane database from January 2003 to December 2017. So the first list of recommendation is related to the drug interaction. As I said earlier, very commonly used drugs also interact with OC pills and may reduce their effect. So we have to know that if the patient is already on any medications, out of which important is antiepileptics. So for women on antiepileptic drugs, it may compromise the efficacy of oral contraceptive pills. And in such women, you might have to prescribe high dose pills as high as 50 microgram of ethinyl estradiol. Lamotrigine is a special case. If any patient of yours who is on lamotrigine, please consult with her physician before giving a prescription of an oral contraceptive pill. Do ask the patient about the history of antibiotic. When on antibiotic, the OCP's user should use an additional method of contraception, or they may experience the symptoms like intermenstrual bleeding when they are on antibiotic. Low doses of benzodiazepine, nitrazepam, caffeine, prednisolone, cyclosporin, they also may be effective in oral contraceptive users. And oral contraceptive users may require larger doses of aspirin, paracetamol, acetaminophen, morphine, all these basic drugs. Those women on antiretroviral therapy and oral contraceptive pill shouldn't be given together because it affects the metabolism grossly. So those who are on antiretroviral therapy, don't prescribe oral contraceptive pills. Now, as far as the investigations are concerned, we all always worried about the risk factor. So what the recommendation says for the investigations: obtaining a thorough past medical and family history and calculating the BMI, measuring the blood pressure are important. Measuring blood sugar levels and OGCT may not be recommended unless the women are overweight or have other diabetic risk factors. Asian Indian race is a high risk. Practically speaking, in my practice, I do blood sugar levels and OGCT of all the patients before prescribing any oral contraceptive pill. Evaluation of lipids should be done only in overweight women with PCOS, but it may not apply to Asian Indians. Pelvic examination, as I had mentioned, pelvic examination and pap smears are not required before prescribing the oral contraceptive medicines. Thrombophilia screening is recommended only in presence of family history of venous thromboembolism in the first degree relative. Now, we are always worried that, okay, you have prescribed the pill for acne or a hirsutism, but what about long term? If that patient needs these kind of pill for 6 months, 1 year, 2 years, 3 years, are we safe in giving such medicines for a longer duration? So, what the evidence is, smoking, hypertension, and diabetes are risk factors for cardiovascular disease. So, controlling these factors can reduce the long term risk. So whenever you are prescribing the OC pill along with these conditions, then yes, we have to encourage for the lifestyle modification to a major extent. Increased risk of DVT in women with oral contraceptive pill warrants that DVT should be ruled out in all the women on contraceptive pills who complain of edema on their feet or leg pain. Obese women who are on the pills are likely to experience it more than the obese non-users, and that's why there has to be a word of caution when you are using COCs in obese patients. Increased risk of MI is mainly because of the hypercholesterolemia as compared to the non-users. So again, there is a word of caution, and you can ask her to follow up with her lipid profile. Mild dyslipidemia is not on contraindication. It's a very, very commonly seen the condition these days for the ladies, especially around 40. But the women should be made aware that the OCPs can change the lipid profile, and therefore it should be monitored depending upon the metabolic risk. Increased risk of venous thromboembolism and stroke among the contraceptive users with dyslipidemia is compared to the without dyslipidemia is less. So again, it has to be used with caution. Slightly, there is an increase in the risk of breast cancer as reported in women who take contraceptive pills. And that's why it requires a stringent follow-up. My practical advice to you, don't prescribe oral contraceptive pills for any girl, any woman who has a strong family history of breast cancer. Higher risk of cervical cancer is also reported in women who use contraceptive pills, especially with the increased duration of the pills. So therefore, it may be better to restrict the use for the shorter duration. The evidence of this particular risk of cervical cancer is very low. So not to get scared, do the pelvic examinations and pap smears along with your gynecologist friend on a regular basis so that such risks can be picked up at an earlier stage. Healthcare professionals should be aware of the impacts of OC pills on the cardiovascular and the bone mineral density. Now, this is something very important when it comes to the oral contraceptive pill use in a young patient, because it is going to affect the bone mineral density for her. Venous thrombosis risk, hypertension, lipid profile, endometrial and breast cancer, and liver cancer. So all these are the main things which, as a health professional, we should be keeping in mind. Now, this is something related to your area, the recommendations for acne and hirsutism. So what has been seen, the evidence says that if you have to treat inflammatory acne in females, estrogen containing COCs are more effective. Now, all the generation of contraceptive pills contain ethinyl estradiol in various doses. So you can choose any of them when you are going for individually only the acne treatment. If it is associated with hirsutism, then ethinyl estradiol with drospirenone or ethinyl estradiol with sapropterin acetate combinations, it improves the hyperandrogenic parameters significantly without affecting the insulin resistance adversely in Indian women with PCOS. So probably for those who have got acne, it is mainly the ethinyl estradiol component which is going to work. Those who have got acne with hirsutism, combination with drospirenone or sapropterin acetate should be preferred. When it comes to prescription for hirsutism in a young girl, OCPs may be prescribed in adolescents with hirsutism accompanied by menstrual irregularities. For most of the women, there is one OCP over another as an initial therapy is not suggested. So commonly the observation is all oral contraceptive pills appear to be equally effective for hirsutism, and the risk of side effects is low. The progestin is to be preferred in these patients are anti-androgen progestin such as sapropterin acetate and drospirenone. So preferably the use of oral contraceptive containing the progestin with low androgenic activity is always preferred. If hirsutism does not respond despite of 6 months of monotherapy, then anti-androgens can be added. COCs containing ethanyl and anti-androgen, when combined with metformin, gives a better result than COCs alone. So this is something which we do follow in a preconceptional phase, even in gynecology. So that might be helpful. Epilatory measures need to be used in conjugation with the oral contraceptive pills, and the evidence of this is moderate. So I think for your practice, if you use both the treatments simultaneously, the result will be better. So finally, the take-home message from my side would be OC pills is definitely a first-line therapy in PCOS along with lifestyle modification. I do personally use oral contraceptive pills to a greater extent. Counseling and medical evaluation before starting the pill is a safe practice. Long-term use is, of course, with caution and with regular follow-up. Ethanyl contains the oral contraceptive pills is better for inflammatory acne, and combination of ethanyl with drospirenone and ethanyl with sapropterin acetate works well with hirsutism. I thank you all of you for having me here and listening to me patiently. Thank you very much.
Ma'am, may I request you to stop sharing your screen, please?
Yeah, sure.
Thank you so much, ma'am, for that very crisp yet extremely detailed presentation and for sharing all the recommendations and guidelines with us. Our next speaker for today is Maitreyi Bokil. Maitreyi is a passionate nutritionist and exercise physiologist with masters from the Columbia University, New York City. She currently practices as a nutritionist, sports nutritionist and exercise consultant, having been a counselor for the Columbia Dental School and a group fitness instructor in Miami and New York. She also has completed 5 marathons as an extremely committed triathlete. We welcome you, Maitreyi. She will be discussing with us the role of diet and exercise in PCOD. Over to you, Maitreyi.
A very good morning to everyone. I'm delighted to be a part of this highly esteemed panel and where for once lifestyle intervention and nutrition and exercise specifically is given its due importance. My name is Maitreyi Bokil. I'm a nutritionist and exercise physiologist. Today we will be talking about nutrition and exercise in PCOS and how physicians can give simple, basic nutrition and exercise prescriptions till the client reaches a person like me for then a more detailed investigation. I'm extremely sorry I couldn't be there with you in person. If all goes well, at this point, I would be in my last leg, that is my running leg of the half Ironman distance triathlon in Kolhapur. The points of discussion for today's short talk are the 2 types of PCOS, the importance of nutrition practices in PCOS, a basic nutrition prescription for PCOS, what is the role of exercise in PCOS, and then a basic exercise prescription for PCOS, which can be given by a doctor till the client reaches an exercise physiologist like me. A PCOS is a common endocrine disorder, depending on which criteria has been used for diagnosis, it affects anywhere with between 4 to 20% of women in the reproductive age. It is a diagnosis of exclusion where 2 of the 3 conditions need to be present. Either it has to be irregular or absent ovulation, hyperandrogenism, or the presence of polycystic ovaries. Now, while obesity is a condition which is seen across the board nearly in all the women with PCOS, there is a certain 20% of women with PCOS or PCOD who are not obese, and we call them as the lean PCOS. But here's the catch: regardless of whether the woman is obese PCOS or lean PCOS, there will be insulin resistance. Now, these are just the 3 diagnostic criteria which are used for diagnosis of PCOS. Let's talk about the differences between the obese PCOS and the lean PCOS. Like I said before, they both have insulin resistance, just that obese PCOS, almost all of them have insulin resistance, whereas in the lean PCOS, we have a certain, a lesser percentage of women with insulin resistance. BMI in the obese is above 30 kg per meter square. In the lean, it is usually above 25 kg less than 25 kg per meter square. Obese have a greater prevalence of metabolic disorders. They have a full body fat deposition, which puts them at a higher risk of morbidity and mortality at a higher risk at a younger age. And this is why they're usually prescribed to lose weight. Whereas in the lean PCOS, they have higher levels of the hunger hormone, which is ghrelin. They have a greater deposition of fat around the stomach. So compared to their age-matched controls, they have a greater waist to hip ratio. They also have a weaker antioxidant system, greater cardiovascular markers, higher or elevated LDL and total cholesterol markers. Now, because they are lean and they don't need to lose weight, they are usually prescribed to maintain their weight and get onto a healthier lifestyle pattern. What are the similarities between the lean PCOS and the obese PCOS in terms of the diet? They both need a diet which is high in good quality protein, high in vegetables, lentils, and beans. They need a diet which is moderate in fruits, grains. They need a diet which is definitely very low in refined grains, refined foods, added sugar, fried foods, honey, jaggery, and also milk. What are the exercise similarities between the 2 types of PCOS? They both need to do weight training, full body, for a minimum of 2 non-consecutive days of the week. And they need to be engaging in heart strengthening, bone strengthening, cardiovascular activities for a minimum of 150 minutes per week. We will get into the details a little later. Now, what is the role of diet and PCOS? A well-planned diet can help reduce insulin resistance, increase insulin sensitivity, reduce cholesterol markers, and reduce the risk of developing a cardiovascular event in the future. High protein, high fiber diet has been shown to reduce the waist to hip ratio. A well-planned, sustainable portion controlled diet, along with consistent exercise, will definitely help reach the goal weight, whether it is weight loss, whether it is weight maintenance, or whether it is weight gain. So now let's quickly come to what is the basic dietary prescription that a physician can give a woman or a girl with PCOS. At the bottom line, you have to tell them to start with the protein first. Start with the protein first, because protein has a very high satiety value or a very high food related satisfaction value. Now, the easiest protein found in Indian households is going to be dahi. It is also an animal protein, which makes it a very good quality protein. You have to encourage them to be eating low fat dahi. The other good quality protein sources include paneer, they include chicken, they include fish, they include eggs. They include tofu. The next thing that you would ask the patient to consume on her plate is the vegetables, be it raw vegetable or cooked vegetable. Again, vegetables are higher in fiber. They have a higher amount of chewing that's required. So all of this increases the satiety value again. Vegetables are also full of vitamins and minerals, very, very important for women with PCOS, especially to treat their skin condition, their acne. The third thing that you would ask them to eat is the lentils and beans, a fantastic source of complex carbohydrate and a lot of fiber. This makes lentils and beans also a food with a very high satiety value. Lentils and beans in the Indian diet are often mistakenly taken for protein. They are not great sources of protein. 1 cup, that is around 200 grams of cooked lentils and beans, will not give you more than 6 grams of protein, and this is vegetarian protein, which makes it not a complete protein source. But they are definitely excellent sources of fiber. So they should be number 3 on the list. The fourth food item, or the last food item which you should ask women with PCOS to consume should be grains and rice. Now, this is not to say that they are bad or that they need to be excluded, or we need to keep our girls with PCOS off of grains. This is just because what happens with grains and with rice is that the satiety value is a little lower. So when you start a meal with roti or you start a meal with rice, you end up eating a little more than you would if you start your meal with protein. Please let me know if you have any questions about this. I would love to answer any questions. So just reiterating the basic guidelines for PCOS here, you have to advise them to follow this sequence for every meal. Protein comes first in the form of dahi, tofu, paneer, chicken, eggs, or fish, followed by the fiber. Fiber can be either vegetables or it can be in the form of a salad. This is followed by, again, another source of fiber, which is lentils and beans. The last thing should be grains or rice. And you must advise them to maintain the similar structure for all meals. For example, a typical Maharashtrian breakfast is pohe, upma, khichdi, all of that. All of these things are carbohydrates, but there is no protein. Now, the easiest way to make this a complete protein is going to be to add dahi to all of this. And it also tastes great. So you have to suggest them to eat dahi khichdi, to eat dahi pohe, to eat uppit with a cup of dahi. And then after that, to snack on a few salad vegetables like a kakri khawa or a gajar khawa. So then this makes it a complete meal. The next thing is snack guidelines. We all are, big snackers. 4 p.m. to 5 p.m. is snack time. 11 a.m. is also snack time, where these women can tend to reach out for foods which are a little bit higher in sugar, like samosa, like chakli, like khakra. Okay, so we have to advise them to snack on foods that do not cause an insulin spike. Again, it will be protein options like whole eggs or egg whites, depending on what the cholesterol profile is like and what the weight goal is like. You can also recommend to the patient to probably have a protein supplement, be it plant protein or whey protein. If you don't want to give her too many artificial sweeteners, plant proteins also come unflavored. So I usually ask my PCOS clients to take those. You can also request that they snack on cut vegetables with nuts. Nuts being fat they also have a great satiety value. There's a lot of chewing involved, which helps in the feeling of fullness. The only thing you want to be careful of is you don't want to ask them to snack on like fried nuts or salted nuts. The nuts need to be plain and unsalted, preferably walnuts or almonds, because they usually have the better nutritional profile. If they want to consume a fruit, suggest it that they restrict their fruit intake to either pre-workout, during workout, or post-workout. Now moving on to exercise and PCOS. So it is a well-known fact that exercise improves the number and the translocation of the GLUT4 receptors on muscle surface. GLUT4 receptors are responsible for glucose uptake on the muscles. They enhance insulin sensitivity. And of course, then they reduce hyperinsulinemia. They reduce risk of cardiovascular conditions. PCOS is also associated with a lot of mental conditions. The patient can tend to feel depressed and overwhelmed with the diagnosis. So engaging in regular structured exercise will help enhance that patient's psychological well-being, will help her improve her body confidence. Exercise, when combined with an appropriate diet, can help improve the waist to hip ratio, and in the long run will also help weight loss. Definitely, exercise improves the strength of the skeletal system. It also reduces the risk of age-associated fat gain and muscle loss, which is called as sarcopenia. So it is very important that not just women with PCOS, but all the women, regardless of their age, engage in exercise, and more importantly, engage in regular weight training to reduce the risk of sarcopenia and then avoid the risk of falls, fractures, and injuries, and so forth. So what are the exercise guidelines for PCOS? They're not any different from the general exercise guidelines for the population. So the clinical consensus recommendations for PCOS is that adults need to be engaging in a minimum, mind you, this is minimum of 150 minutes of moderate intensity exercises per week, including 2 days of muscle strengthening, or 75 minutes of vigorous exercise per week, including 2 non-consecutive days of muscle and bone strengthening. Here's what I say to this. I usually tell my clients to start with 150 minutes of basic cardiovascular exercises plus 2 non-consecutive days of muscle or bone strengthening. In adolescents, at least 60 minutes every day of moderate to vigorous physical activity, including those that strengthen muscle and bones at least 3 times a week is recommended. Now, if you're a very busy person and you don't have you don't have a lot of time every day, 150 minutes can be divided into 10-minute bouts, but you have to make sure that in a day you get at least 3 10-minute bouts. This is also a great guideline for a person who may not be physically active, to prevent them from being overwhelmed with the idea of, also starting a healthy diet and then going to the gym. You can ask them to just walk for 10 minutes, 3 times a day. So what this means, what do the guidelines really translate to? So in exercise physiology, there is something called as the FIT principle, which is frequency, intensity, type, and time of exercise. So let's talk about the FIT principle for aerobic activity first. The frequency would be thrice a week. Now, depending on the fitness level of the person, there is something called as a talk test, which is the best way to gauge exercise intensity. You have to be able to carry on a conversation fairly decently, or with your fellow exercise companion, or you should be able to sing your favorite song without going completely out of breath. If you can do that, then you are at a low to moderate intensity. If you're not able to do that, then the exercise intensity is too much for you. If the person is just embarking on a fitness program, you have to advise them to do a low to moderate intensity fitness routine or a low to moderate intensity cardiovascular routine using the talk test. Carry on a conversation, sing a song. If that person is of a high fitness level, then we still recommend low to moderate intensity exercise twice a week, followed by once a week of high intensity exercise, whereby either you're not able to carry out the conversation, or you exercise at 70 to 80% of your age predicted maximum heart rate. Now, what is the type of exercise that we want them to engage in? Because this is aerobic fitness, the exercise can be walking. It can be walking on an incline for a little more resistance, a little more intensity, a little more glute, hamstring, lower back strengthening. It can be cycling, it can be swimming, it can be jump rope, it can be the rowing ergometer in the gym, or if they have a little higher fitness level, it can be a run or it can be a jog. Now, the time is very individual. It could be a 20-minute, 80% age predicted maximum heart rate session, or it could be a 60-minute, 60% age predicted maximum heart rate session. So anywhere between either 20 to 30 to 60 minutes, depending on the time at hand, the participants' willingness, and their fitness levels. Now, what is the FIT principle for bone and muscle strengthening? We usually recommend 2 non-consecutive days of the week, so that there is time to get over the the DOMS, or the delayed onset muscle soreness, which usually sets in after a weight training workout. It can give the participants enough time to recover and be ready for their next session. The intensity, it varies again according to the comfort level and the fitness of the person concerned. If she is a novice to weight training, then we usually recommend to just start with body weight, front kicks, side kicks, planks, assisted push-ups. She can then move on to lightweight resistance tubing before moving on to the gym machine. Now, the great part of the gym machines is that you are supported and only the limb in question moves. So chances of injury are a little bit lower, provided that your machine apparatus is set correctly. If she is more experienced, then she can definitely start with the dumbbells, barbells, kettlebells, battling ropes, Swiss balls, Bosu balls. Then it moves on to infinity. What are the type of exercises that we want them to engage in? If we are talking about a person who is new to exercise, then we would advise them to do chest press, leg press, lat pull, chin ups in the gym. Now, the point here is to make sure that she moves her entire body. She moves all the major muscles in the body. The same exercises can be done at home using body weight, using resistance tubing. Okay, if the person is a little more experienced and she is willing to, go through exercises which may be a little more complex in nature, then she can start with squats. She can start with full push-ups, lunges, pull-ups, deadlifts, and planks. Again, the point here is rather than spending an entire session doing abs or doing bicep, tricep, let's target the exercises which cover a greater surface area, so that makes the person more efficient at using blood sugar, and it makes the person also more efficient at using fat for fuel, because the more you exercise, the more you trigger the formation of muscle mitochondria, which are the powerhouses of the cell. What is the time that we should advise them to spend in weight training or in muscle or bone strengthening activities? Now, again, this is very subjective. We don't talk about a time. We say as much time as it takes for a new person to do one set of all the exercises targeting the major muscle groups. And if she is experienced, then she needs to be doing 2 to 3 sets of each muscle group. And the rep range can be anywhere between 12 to 15 repetitions. She can even go to a level more advanced and take it from 8 to 12 repetitions for 2 to 3 sets, depending on her comfort level. Okay, so before we get a little overwhelmed with the weight training schedule, let me tell you that the basic and the loveliest weight training exercise is Surya Namaskar or Sun Salutation, because this wonderful sequence of movements takes our body through bending, through stretching, through squatting, through push-ups, through hyperextension. And all of it is in a lovely flow along with regular breathing, and it helps us relax. So if your participant has never stepped foot into the gym, or she is very intimidated at the thought of doing push-ups and squats, you must encourage her to start doing Surya Namaskars on a regular basis. That also helps. Now that brings us to, what is a basic exercise prescription for a girl or a woman with PCOS? Depending on her fitness level, you can request her to either start walking, jogging, cycling, or swimming, or doing jump rope or whatever cardio modality is there around her 3 times a week for up to 60 minutes. If you say 60 minutes, it can, again be like, that's a lot of time, but you can say, depending on your time at hand, something is better than nothing. If she is engaging in an exercise bout which is smaller than 10 minutes, then she needs to do 3 exercise bouts in a day. If they are more than 10 minutes, then either increase the intensity or do it consistently every day. And for muscle building and bone strengthening, she can engage in Surya Namaskar 2 days a week for up to 20 minutes. And then, on good days, she can, probably do up to 100 Surya Namaskars. And when she feels comfortable, then she can seek help either of an exercise physiologist or a very qualified personal trainer who can actually supervise her through a nice strength training routine, which then she can take up on her own. Now let's do a quick recap. So what is the basic nutrition prescription that you can give a girl with PCOS? Always encourage her to start with the protein first because they have the highest satiety value. Remember, dahi is animal protein, is present in all our Maharashtrian households. So nothing like starting the meal with dahi. The second thing is she needs to be eating all her vegetables, be it in the salad form or be it in the raw form or the kosher form. That is the second and third. The third thing is that lentils and beans, a great source of fiber, fantastic source of complex carbohydrate, not a very good source of protein though. But because of the fiber content, we put them at number 3. They're also a good source of iron for, non-heme iron for all the women with PCOS who may have lower hemoglobin, but you always want to ask them to sprinkle a little bit of lime, which then enhances the absorption of iron. The fourth and the last thing you want them to eat are your grains and rice. So you have to tell them that instead of saying, that for a meal I am eating roti, rice, sabzi, and dal, you want to change your narrative and start with saying, I eat dahi, sabzi, dal, and roti. Even saying it like this makes a difference. You want to encourage them to snack on protein. You want to encourage them to snack on vegetables and keep the fruits for pre-workout, during workout, and post-workout. You also want to encourage them to be drinking a lot of water. 2 liters is the minimum. We usually encourage anywhere between 2.5 to 3 liters. Exercise, just like I said a little bit earlier, the basic exercise prescription is walk, jog, cycle, swim for 3 days a week for up to 60 minutes, depending on how much time you have. The basic weight training exercise is Surya Namaskars, which all of us are very well versed with. So please encourage them to engage in Surya Namaskars for up to 20 minutes. Or if they are comfortable, seek help of an exercise physiologist or a qualified gym trainer to take them through basic body weight training movements like front leg raises, side leg raises, planks, assisted push-ups, chair squats, so that they start moving their muscles, they start building their muscles, and as they get better with the activity, then they can move on to joining a gym or hiring a personal trainer, so on and so forth. This brings us to the end of my small lecture here. These are my references. Thank you so much. Thank you for this opportunity, Dr. Vaidya and Dr. Gire. If you have any questions, doctors, please send your questions to these two doctors, and I will definitely get back to you. I'm going to try my best to make it to the panel discussion on Sunday. I hope to see you all there. Thank you so much.
Thank you. Just allow me a moment while I share my screen. Thank you, Maitreyi, for that very articulate and lucid talk, especially for the final recap. That was very crisp and absolutely nailed all the information. Our last talk for today is by Pune's very own endocrinologist, Dr. Uday Phadke. Dr. Uday Phadke is a fellow of the American College of Endocrinology, has an experience of several phase 2 and 3 clinical trials, has numerous publications in peer-reviewed international journals and chapters in the textbook of diabetes and endocrine manual. He is also a postgraduate guide for students of diploma and fellowship in diabetes under the Maharashtra University of Health Sciences. He is a recipient of the Shrimati Bhandarkar Award for Academic Excellence and has recently taken over as the Director of Endocrinology and Diabetes at the Sahyadri Group of Hospitals. Dr. Uday Phadke has never needed an introduction. I invite you to come and share your talk and your screen with us, sir. Dr. Phadke is going to share with us a rational approach to investigations and to prescribing anti-androgens. Over to you, sir.
Thank you very much. And thank you for the invitation to be a part of this particular program. Very glad to be sharing my screen here. And what I'm going to do today is to make a few things clear about how we actually investigate polycystic ovarian syndromes and how we go about the different androgens that are available to us. So basically, the polycystic ovarian syndrome is really a clinical diagnosis, and it doesn't actually require a test to prove in or disprove PCOS. So any combination of varying degrees of hyperandrogenism and ovulatory dysfunction is called polycystic ovarian syndrome unless otherwise proven. So there are some disclaimers which we need to take out before we say that this is PCOS. When we mean ovulatory dysfunction, basically it means irregular cycles or complete amenorrhea or DUB or infertility. But at the same time, we must also remember that some anovulatory women may have regular menses. When we talk about hyperandrogenism, we are typically talking about acne, hirsutism, and male pattern alopecia. And in certain extreme cases, we could have clitoromegaly and change in voice, although that's uncommon with the degree of hyperandrogenism that is seen in PCOS. PCOS often has associated metabolic abnormalities, typically obesity, diabetes, dyslipidemia, and NASH. So, and it's a syndrome. It's not a single disease. There are many causative theories. And obviously, when there are many causative theories, one doesn't know single unifying cause as such. And hence, treatment approaches are going to differ. If we look at the diagnosis of PCOS, I often see a lot of tests being done before patients come to me, and a lot of confusion arises right at that stage. But as I said, PCOS is a clinical diagnosis and per se does not require a specific test. Dr. Ashwini has already told you about the Rotterdam criteria, that you can just have a clinical combination of hyperandrogenism or ovulatory dysfunction, and you don't need an ultrasound all the time to diagnose PCOS. This ultrasound is a funny thing because otherwise normal women with completely any absence of any endocrine abnormality may show polycystic ovaries. So be very careful about diagnosing PCOS on the basis of ultrasound alone. Also be very careful not to diagnose ovulatory dysfunction in the first 2 years after menarche, because the entire endocrine axis has not yet matured and ripened, and therefore periods can become or may remain irregular in the first 2 years after menarche. Also remember that in most people or most women, even with frank PCOS, androgen levels could be normal, and there is no specific cutoff point for androgen to be called high. The mere presence of acne or hirsutism is enough to tell us that the androgen levels are elevated. And if one has to use ultrasound for diagnosis, remember that the ovary should show more than 12 follicles between 2 to 9 millimeters. So you can't have a single large dominant follicle, and the ovarian volume has to be more than 10 ml. But what is most important is, to be called polycystic ovarian syndrome, we must exclude several other things which look like PCOS. So these are hypothyroidism, hyperprolactinemia, Cushing's, congenital adrenal hyperplasia, virilizing, adrenal tumors, and acromegaly. In fact, let me tell you that the investigations that we do are mostly to rule out these causes rather than to prove PCOS as such. So that's the real importance of testing in PCOS. And statistically, actually, if you look at women in the reproductive age group who have hyperandrogenism and ovulatory dysfunction, 90% of them are actually likely to have polycystic ovarian syndromes. There are certain pointers in examination, and these are very clear: obesity, acanthosis nigricans, male pattern hair loss and hirsutism, increased muscle mass, and clitoromegaly. Of course, clitoromegaly is something which is a little extreme, but you will find that many people with PCOS do tend to have a higher muscle mass because of chronic androgen overexposure. And if they do have Cushing's, Then you have, of course, the typical features of Cushing's. I'll show you an illustration. And of course, acromegaly, similarly. This is typical acne, male pattern baldness, severe hirsutism in this particular case, along with severe acanthosis nigricans. A typical case of acromegaly, you can see her facial features, her large hands, the typical prominence of the supraorbital ridges, prognathism, protrudence of the jaw, lips. And this is a child. You can see here, this is actually a female child. You can see here with a lot of lanuge hair on the face, an extremely puffy face. This is actually a drug-induced Cushing's. This child was being fed steroids for so-called respiratory symptoms by her GP or whoever. And this is a typical Cushing's. You can see the chubby face, the moon face, the acne, and so on. So these things are usually quite evident on examination itself. Now, what kind of tests would we do in polycystic ovarian syndrome? As I said, one test would be to look at the androgen status, not to say whether it's high or low, but mostly to rule out androgen producing tumors where the testosterone is very high. See, within the normal range, a patient can have hirsutism with completely normal looking testosterone. So our aim in doing androgen levels is not to miss a tumor or virilizing congenital adrenal hyperplasia. The second set of tests that we do is to rule out other diseases presenting as PCOS. As I said, hypothyroidism, hyperprolactinemia, Cushing's, adrenal tumor, and acromegaly. And then the last set of tests are tests which are relevant to the associated metabolic syndrome, which means diabetes, NASH, dyslipidemia, etc. Now, what about androgens? The commonest test that we do, I see, as I said, I see practically 5 or 6 PCOs referred, and I see so many tests, and the patients have spent thousands of rupees doing these tests because so many labs now offer all kinds of combination tests, which are often very expensive. Remember, the simplest test to test androgen status is total testosterone. This is still the most relevant test in women with hyperandrogenism. Again, as I said, don't be put off or disillusioned because it is in the normal range, because most people do have a normal looking testosterone. I'll explain the reason why. Also remember that assays are not completely accurate, and there are issues with many labs about quality control. The best assay is called LCMS, which is liquid chromatography mass spectroscopy, but very few people use it because of the expense. The upper limit of normal is about 60 nanograms per deciliter. You will hardly find people above this most of the times. But if the levels are crossing 150, this would make you suspect tumors, and these people have to be then actually investigated for that. I also see a lot of people doing a free testosterone as well. Now, free testosterone level is a difficult test to perform. The assays are not very standardized. It requires special equipment. And again, levels are likely to be normal even in the face of clinical androgen excess. So just doing a free testosterone without really the need for it is going to be very difficult. I would seriously advise you not to do a free testosterone. So this is very, very important. And again, as I said, they have very poor sensitivity and specificity, and best to avoid free testosterone. If at all you want to have an idea of how much free testosterone is available, you can do what is called a free androgen index, which means you measure testosterone along with the SHBG levels, the sex hormone binding globulin levels. So this will tell you how much testosterone is available freely to the receptors. Now, this means that you need to measure SHBG also, which becomes an expensive process. But as I said, the very fact that the patient has hirsutism or acne or male pattern baldness means there is excess of testosterone. Why do you really need to measure all this? It's not really important in therapy unless you're doing some kind of a clinical trial or you want to measure some objective indicators in follow-up. Otherwise, these are expensive. Again, they are difficult to do. They are not available. If you send it to your nearby lab, 90% chances are that they will outsource it to someone. It doesn't make sense to me. I also see a lot of prescriptions, particularly from dermatologists, for DHEAS. Now, what is this DHEAS? DHEAS is dehydroepiandrosterone. It's a precursor of testosterone, and it's almost entirely produced in the adrenal, but it does not have any intrinsic androgenic activity. So just the DHEAS level doesn't really mean anything. If, as I said, in a person who is hirsute or has acne or has clinical signs of hyperandrogenism, the only real place for DHEAS would be maybe in adrenal tumors or sometimes in CAH. And for that, your values need to be really high, and CAH would be very different. The testosterone there also would be quite different. And we have another good test to diagnose congenital adrenal hyperplasia. So DHEAS routinely is not necessarily a very good idea. Androstenedione is immediate precursor to testosterone, and there is an excessive production in the theca cells of the polycystic ovaries. Now, again, it's not really recommended to test androstenedione levels, but maybe slightly more sensitive than testo, but obviously less available and more difficult to perform and very expensive. So again, not really necessary. What about DHT? In androgens responsive tissues, particularly the peripheral pilosebaceous unit, we know that the testosterone is converted to DHT via 5-alpha reductase. And the affinity of binding to the androgen receptor of DHT is 10 times that of testosterone. So DHT naturally is a very important hormone. And sometimes you will find that in a person with clinical signs of hyperandrogenism, DHT is elevated, but testosterone is quite normal. Again, however, routine testing is not advocated, and you'll often find that in hyperandrogenic women, the DHT is elevated because of increased local 5-alpha reductase activity. Now, a metabolite of that is called androstenedione and can be measured to gauge the peripheral activity of testosterone. But again, routine measurement are not recommended. So if you see, you can measure testosterone, free testosterone, SHBG, androstenedione, androstenediol, DHT, DHEAS, and all kinds of other things, along with 17-hydroxyprogesterone. And the whole thing will cost you upward of 10 to 15,000 rupees. And all of that is completely unnecessary, really. So the significance of androgen measurements is that you will find testosterone to be normal in most patients. So that is something which you have to keep in mind. The real value is to test it in people, or the real value is to rule out androgen-producing tumors or congenital adrenal hyperplasia, where your testosterone values are going to be more than 150. As I said, other androgen markers do not have a significant place. Now, the other things which I did not say is 17-hydroxyprogesterone. Now, 17-hydroxyprogesterone is a test that we do, and this is basically to test whether there is an enzyme block in the adrenal glands in the whole steroidogenic pathway. And the commonest thing which causes a rise in 17-OHP is a defect called 21-hydroxylase deficiency, which, as you know, is the commonest cause of virilizing CAH. But remember that the values are often more than 1,000 nanograms per deciliter, or they need to be at least 200 to say that this is suspicious. So very borderline values don't necessarily need to be evaluated. If you're not sure, what we do is we stimulate this value by giving ACTH from above externally, and then now clearly the value has to exceed 1000. So this is a good test to diagnose at least 21 hydroxylase deficiency. Of course, there are many other forms of virilizing hyperplasia. I'm not going to go into them, but just remember, it would be good to include 17-hydroxyprogesterone as one of the tests that you should do when you're looking at hyperandrogenism. And then there are other tests. Again, these tests are more to rule out other problems. So for example, a high FSH in the presence of amenorrhea tells you about ovarian failure. So AMH, which is independent of menstrual phase of the cycle, is a good indicator. LH is often high, but we don't decide anything on the basis of LH, not in routine PCOS treatment. Perhaps Dr. Ashwini would like to have that test to decide on her infertility treatment. But in a clinical setting of just PCOS alone, we don't really require FSH-LH. Prolactin, remember, we are doing prolactin to rule out serious hyperprolactinemia. And this is another very irritating thing that I see every day, that borderline prolactin. So let's say if the prolactin level is less than 20 in the lab, a value of 25 is started on cabergoline. Remember, this is not significant. If you're dealing with prolactin secreting tumors, the values are like 100, 200, 500. Also remember that many drugs which are commonly used cause prolactin elevation. So be careful. I've seen people spending 10,000 rupees, 15,000 rupees on MRIs for a prolactin of 30. It's not indicated. So you may do a prolactin to rule out serious hyperprolactinemia, but don't jump to any conclusions just because it is borderline. TSH must be part of the evaluation because hypothyroidism does cause oligomenorrhea. But remember, and this is a separate discussion, don't start treatments for so-called flimsily elevated TSH values. There is a complete science to all of that. Ovarian adrenal tumors, as I said, testosterone needs to be 150 and plus. If that, you do a CT or MRI. For Cushing's, excuse me, I just need to take this urgent call for a second. Just give me a second. Hello. Sorry about that. I had to take that. So for Cushing's, of course, you do a dexamethasone suppressed value. You give 1 milligram of dexamethasone at night, and next day you do a cortisol in the morning. This will tell you whether the patient has Cushing's. But to rule out a exogenously administered Cushing's, that means Cushing's due to exogenously administered steroids, you will find that just a baseline cortisol at 8 a.m. will be very, very low. So any person who has a low baseline cortisol in the presence of Cushing's syndrome features, it is because of exogenous steroid. There is no role for a 4 p.m. cortisol. I don't know why people do it. There is no role for it. For acromegaly, it is a IGF-1 or a growth hormone. I'm going to skip this, not very important. If this comes up, we'll discuss that. And for tests for metabolic syndrome. Now, this is something which most people keep doing without actually much relevance. I would not say much relevance, but I don't know what exactly is achieved by that. So serum insulin testing is not really required. A person who is obese, who has acanthosis, who has hirsutism, who has acne, who has irregular periods, is bound to have insulin resistance. And we don't need to prove it. We don't need to prove it. You can assume that this person is insulin resistant. There are many other simpler tests or specific tests to diagnose that, which includes high triglycerides, low HDL, and just a clinical examination. So insulin testing or the HOMA IR2 and all these are extremely expensive. These are not required. Perhaps I'm being old-fashioned, but really speaking, let me tell you, you don't need to do these tests. Certainly, I would do a blood sugar and a HbA1c. I would certainly do a lipid profile. I would always do a SGPT and a GGT to rule out NASH. You will be surprised how many people with PCOS actually have serious fatty livers. And we then come to the second part of my topic, and that is about anti-androgens. Okay. Now, the whole point about approaching androgen excess in PCOS is to reduce androgen level, or not necessarily the androgen level, but the effect of androgen on tissues. And there are several ways of approaching this. So you either reduce the production of androgens, either from the adrenal, from the ovary, or what you do is you increase the binding of these circulating androgen to the binding protein, which is SHBG. And by doing that, you reduce the freely available testosterone, or you block the effect of testosterone at the receptor level. And so these are the approaches, and all the medicines that we use in PCOS to negate androgen action act through one of these mechanisms. I'll quickly go through the different mechanisms or the different drugs available to us, and then tell you how we use them. If you look at the androgen receptor blockers right at the periphery, you have two types. You have the steroidal types and the non-steroidal types. The non-steroidal types, that is flutamide and calutamide, they're effective, but we don't use them because flutamide often has fatal liver toxicity, which is idiosyncratic. It's dangerous to use flutamide. It's given up. So let's block that. About the steroidal androgen receptor blockers, we have two very important ones, spironolactone, and we have cypretron, which is not used alone, but as a part of the oral contraceptive pill. Many pills now contain ethinyl estradiol with cypretron. This typically acts to block androgen receptors. Then you have what are called the selective androgen receptor degraders. So they degrade the androgen receptor, so they prevent the action of androgen. We still are in trial phase for most of these drugs. But one drug, dimethyl curcumin, is allowed for topical use. We don't use this frequently. I don't know if this drug is available in India. Perhaps my dermat friends will enlighten me on this. But this is something which is theoretically available. And then we have the androgen synthesis inhibitors, which again includes spironolactone. This includes ketoconazole, which we do not use because it's quite hepatotoxic. And what we really are doing here is we are reducing synthesis of testosterone in the gonads and the adrenals, and also at the level of the pilosebaceous unit. So even this testosterone to DHT conversion, if we inhibit, that's a kind of androgen synthesis inhibition also. And you know that one of the best drugs to do that is finasteride, although spironolactone and cypretron also works there. The other drugs are antigonadotropins. So what they do, and this is a typical example, is actually the oral contraceptive pills. So by providing a continuous supply of estrogen and progesterone, you inhibit the FSH and LH, and thereby the ovaries become quiet, and the ovaries reduce the production of androgen. Next is anti-ACTH drugs. And this, of course, is using glucocorticoids, but this is done only in the presence of congenital adrenal hyperplasia, not in other situations. And then, of course, is metformin. Now, what metformin does is, it does several things actually. So metformin does reduce insulin levels. And because it reduces hyperinsulinemia, it also reduces IGF-1 level, which itself has some intrinsic LH-like activity on the ovaries, which thereby produces more production of androgen from the theca cells. And also metformin increases the sex hormone binding globulin by reducing insulin resistance. So on one hand, it produces less testosterone. On the other hand, it improves the binding of testosterone to SHBG, and therefore reduces the freely available testosterone levels. So these are the types, 6 important types of ways in which we can do this: androgen receptor blocker with spironolactone, selective androgen receptor degraders, decreasing the synthesis of androgen again, antigonadotropins like OC pills, and of course, metformin. Now, Dr. Ashwini has already told you about the different types of OC pills. Very quick revision on that. Essentially, what needs to be done is that the progesterone component, especially when you're using it for PCOS, should not be androgenic, which means derivatives of 19-nortestosterone, which mean norethistrone, or there are many. But basically, none of them. I mean, there are many pills which still contain this, but we should be very careful not to use this. What should we use? We should use a progestin, which is anti-androgenic. So there are 3 important ones: cyproterone, drospirenone, and dinogest. So make sure that the pill that you use contains one of these, because these are essentially androgenic progesterone, anti-androgenic progesterones. What do? They reduce the testosterone production by inhibiting the gonadotropins. They also increase the sex hormone binding globulin. And as I said, cyproterone also reduces 5-alpha reductase. Also remember that drospirenone is a spironolactone agonist. So it also works the way in which spironolactone works. So this is about the OC pills. All the other things about OC pills have already been discussed. If you look at spironolactone, so I'm going to only consider 2 drugs, spironolactone and finasteride. So spironolactone is an aldosterone antagonist, but what it does is it is a competitive inhibitor of the androgen receptor and also inhibits 5-alpha reductase activity. So it does 2 things at the peripheral level. It has a moderate anti-androgenic effect when administered in large doses. That means 100 to 200 milligrams per daily. Remember that there is a strange thing, that spironolactone also has a mild testosterone or androgen agonist activity on the androgen receptor. So if you give spironolactone to a person who does not have clinical androgen excess, you might actually see worsening of acne because there is this slight stimulation of the androgen receptor. So sometimes we do see this. You can see a slight flare up with spironolactone. The reason is this, because of the partial agonist activity on the androgen receptor. Generally well tolerated, but you may have occasional fatigue, postural hypotension, and dizziness. But very important to note is that it causes menstrual irregularity. This is important to note. Therefore, most of the times, spironolactone has to be combined with an oral contraceptive pill. It has the risk of feminizing a male fetus, as is true with any anti-androgen. So you cannot use it when a woman with PCOS is contemplating pregnancy. You have to stop these drugs for at least 2 months prior. If you look at cyproterone again is a progestational anti-androgen. As I said, it prevents the conversion of testosterone, the action of testosterone at the androgen receptor. Typically well tolerated, although remember that it can cause serious loss of libido in women. And this is not theoretical. I have consistently been told by women, or rather their male partners, that there is something wrong after this pill has been started. And this is well known, loss of libido. And one must remember, and I just recently saw a girl with hepatotoxicity. So you need to monitor liver functions when we are using cyproterone acetate. Otherwise, generally well tolerated. Finasteride, again, very commonly used. It's a type 2 5-alpha reductase inhibitor that inhibits the production of dihydrotestosterone. Finasteride can be used alone, or it can be used in combination with the oral contraceptive pill, where again, the activity actually increases. Again, must not be used if the patient is contemplating pregnancy. Now, dutasteride has both type 1 as type 2 alpha reductase activity, but we do not have much data on dutasteride either in clinical trials or in practice also, although theoretically it appears more attractive. What about single component disease? Just acne or just alopecia? And just like the typical PCOS, both anti-androgens and oral contraceptive pills are efficacious in these disorders, but the effects generally of any of these drugs are evident only after about 6 months, and typically they are best seen at 9 to 12 months. What about combination of two anti-androgens? We know that if you combine OC pill with finasteride or OC pill with spironolactone, it gives better effects. And there are also trials to say that if you combine finasteride with spironolactone, it has, again, a slightly more beneficial effect. So to summarize, my overall approach would be lifestyle modification for all, although this has just a fringe benefit on hirsutism per se. It has more benefit on fertility and ovulatory dysfunction and the improvement in the metabolic abnormalities. I begin oral contraceptive pills with cypritron or drospirenone, especially for irregular menses, and add anti-androgens either at the beginning, depending on the degree of hirsutism, or later. Metformin is a good drug, and as I told you, it has several effects on the androgen milieu. But per se, in trials, metformin alone doesn't necessarily improve hirsutism, but it is known to improve hidradenitis, which is also a part of PCOS. An important point is use all these drugs long term. They are not for 2 months, 3 months, and then stop, and all kinds of things are told to patients, but do stop at least 2 months prior to conception. So I will stop here, and I thank you again for giving me this opportunity to be with you all. Thank you very much.
Just give me a moment while I share my screen. Thank you so much, sir, for sharing your valuable experience and knowledge with us. Dear friends, today is World Leprosy Day, and it gives me immense pleasure to share with you all that on this occasion, our Pune chapter of IIDVL has made a donation to the Department of Dermatology, BJ Medical College and Sassoon Hospital. I invite our president, Dr. Dhanashri Bhide, to share more on this with us. Over to you, ma'am.
Thank you, Purva. Can you stop sharing the screen, please? Yeah, so good morning once again. Today actually is the last Sunday of the month of January, which is observed as World Leprosy Day throughout India. And we are also observing it in a unique way. So every year, actually, Pune chapter is doing few activities on these special days. Last year, we had actually released one patient information brochure in English and Marathi. But this year, we have decided to donate few things to the Department of Dermatology, BJ Medical College, and Sassoon General Hospitals. You will agree with me that even in 2022, we have not been able to eliminate leprosy. Leprosy still has a lot of stigma. The families and the patients are scared and they don't visit the doctors on time because they feel that they will be isolated and no one will marry the girls in the family. So there is a lot of fear still existing with these patients. And as a result of this, what we find is that many of these patients land up into complications because there is delay in starting the treatment. So we do see patients who have trophic ulcers. We do see patients who have claw hand. Loss of digits is still there. And if you look at the resources, like if these patients want to procure all these material, the specialized footwear, or maybe few people need second line of medicines, they are not that easily available, or maybe they are not affordable to the patients. So we were discussing this with the head of the department of BJ Medical College, Dr. Shekhar Pradhan, and what we noticed is that there are at least 15 to 20 patients who need the second line of drugs and they are not available. Also, the MCR footwear is now, it's very difficult to procure, so only one person from Mumbai is providing it. So that's why we decided to buy all these things, the MCR footwear, the second line drugs, that is ofloxacin, clarithromycin, and minocycline in bulk. And we have decided to donate it to the department. So on this note, I would like Dr. Shekhar Pradhan to share his views regarding the type of management that they are expecting, the type of resources that they are having, and little more on this World Leprosy Day. So with this, I end my presentation and I hand over the proceedings to Dr. Shekhar Pradhan. Over to you, Dr. Shekhar.
Thank you, Bide Madam, for giving this opportunity on this day. First of all, good morning to everyone. On behalf of Department of Dermatology, BJ Medical College, I am really thankful. I express my sincere thanks towards Pune chapter of IDVL, especially President Madam, Dr. Bide Madam, and Executive Committee members who have considered extending their support in the form of, say, MCR footwears or self-care kits, as well as the second-line anti-leprosy drugs, especially the minocycline, ofloxacin, and clarithromycin, in giving for the treatment of poor and needy patients of Hansen's. So being on this particular day of World Leprosy Day. So World Leprosy Day, basically it is usually celebrated on last Sunday of January month every year, while in India we celebrate it on 30th of January as a routine. And the theme which has been kept for this particular year is United for Dignity for these patients who are suffering from Hansen's. And if we consider the data, we are seeing approximately 10 to 12 patients, new patients of Hansen's at every month at BJ Medical College, Pune. And I think that this figure is going on increasing. The number of patients do, maybe the new ones and the old ones, they are on the bigger in the number. And I think that the second line drugs would really help in taking of these particular patients who are not able to get these medicines purchased from outside. So I think that this is a good initiative by Pune chapter of IDVL. And I think such similar type of activities between the department as well as with the Pune chapter, we can see in the future also.
Thank you so much, sir.
Yeah.
Moving on to the last leg of today's scientific agenda is the much awaited panel discussion. I invite our president, Dr. Dhanashri Bhide, to come and moderate this panel discussion. Dr. Dhanashri Bhide is a consultant at KEM Hospital and Dinanath Mangeshkar Hospital, Pune. She has received the B.B. Gokhale Award for the first rank in Pune University. She has authored 6 chapters and has 7 publications to her credit. Her areas of interest are endodermatology, clinical dermatology, and lasers. She was also a part of the scientific committee. She was the scientific committee chairperson of the Dermacon 2020 conference held in Pune, and is a member of the SIG Female Genital Dermatosis. Welcome, Dhanashri ma'am. Joining Dr. Dhanashri Bhide as the moderator for today's panel discussion are our 3 speakers that we heard this morning, Dr. Ashwini Margae, Maitrey Bokil, and Dr. Uday Fadke, sir. I welcome you all to join the panel discussion. We have 2 more panelists that will be joining us for this panel discussion. Dr. Vasudha Belgaonkar, who is an associate professor at the Department of Dermatology at the BG Medical College and Sassoon Hospital, Pune. She has 40 national and 38 international publications to her credit. She is a reviewer and is on the editorial board for Index Journals and has authored numerous book chapters. She has 18 years of experience of clinical undergraduate and postgraduate teaching and has an array of awards to her credit, a few of which are the Fogarty Research Scholarship by Johns Hopkins University, USA. She has also been awarded the Outstanding Paper Prize for Oral Presentation in Leprosy and Sexually Transmitted Diseases, and has been felicitated by the Maharashtra IDVL as the best guide, the Dr. A.V. Lonkar Award. Welcome, Vasudha ma'am. Our last panelist to join us today is Dr. Varsha Sidwadkar. She has over 15 years of private experience of private practice, is a consultant at KEM and Zoshi Hospital, Pune. She has many paper and poster presentations to her credit. The recipient of the Dr. A.C. Parikh Award for Best Paper titled Cutaneous Cryptococcus at IDVL Quarterly Meet in 2004. We welcome all the panelists, and I now request Dr. Dhanashri Bhide to take over the panel discussion.
Thank you, Dr. Purva. Yeah, let me share my screen. So is it visible, Purva?
Yes, ma'am.
Yeah. So actually, I'm not able to put it in a full screen mode.
Because it's you need to enlarge, ma'am. It's in the right corner. You will have to enlarge your window.
Yeah, I have done that.
It should show up.
There is this slideshow button next
that
to share.
button is only not visible here. Just 1 minute.
That's actually in docs
stop
form.
sharing.
What is visible on the screen here is that your screen is still minimized. So if you could try maximizing it once more.
So 1 minute. I'll just stop sharing and share it again. Just give me a minute.
Sure, sure. As Dhanashri ma'am shares her screen, let me remind you once again to be sure to fill in the feedback form that has been sent on all the WhatsApp groups. This is essential for you to avail your point for the MMC.
Purva, is it visible now?
It is visible, ma'am, although it is still minimized.
So is it okay if we go like this?
Yeah, I think go. No problem. We can see that.
It's clearly visible, ma'am.
Yeah, go ahead.
Yeah, so good morning once again, everyone. We had 3 excellent talks by the eminent speakers. So after this excellent presentation by all the 3 speakers, now we will start with the panel discussion, which is more or less real life case scenarios. And I welcome all my panelists. We really have a versatile panel today. So I welcome Dr. Uday Phadke, Dr. Ashwini Margade. Maitreyi, I think, will join a little later. Dr. Varsha Sidwadkar and Dr. Vasudha Belgaonkar to please join on the panel. I request all of you to please switch on your videos and please switch on your mics as well. Without wasting much time, we will begin with the presentation, and all the questions from the chat box, if we have not covered, we will try and take them at the end of this kind of a structured panel discussion. So I'll begin with my first case. So now you all know that these are the 3 important presentations in our dermatology office, and we are the first point of contact to deal with these patients, because patients are more worried about their cosmetic appearance. And as a dermatologist, our mindset is to our mind starts thinking about the procedures that we can do, and maybe the lasers what we can use in these patients, and we try to focus less on the evaluation of these patients. But what is important for us is we have to look them beyond the cosmetic appearance. Proper counseling is definitely required for these patients. Also, a referral to appropriate specialists. We do need help of our endocrinology and gynec friends to deal with these patients. And a holistic approach is what we should plan to help improve the quality of life, because these patients are often depressed, they are overweight, they don't feel like going to college, they don't feel like going to work, and so many different problems. If they have infertility, then they are not comfortable at the house, at home. So to reduce the burden of the pharmacologic therapy, a lifestyle management is also extremely important in these patients. So let us hear from our panelists how best we can approach this patient, how early we can diagnose this patient by doing the investigations, and how a kind of a comprehensive approach that we can develop to handle these patients. Now, first question I would like to direct to Dr. Ashwini. Now, often you hear all these different terms like PCO, PCOS, PCOD, and Dr. Phadke just told us that it is more or less a clinical diagnosis, does not require much of investigations. So do we really need to differentiate one from the other, or in practice or on clinical grounds we don't require to do all these things? And also a word about a male PCOS equivalent, because if you read the recent literature, there are reports which talk about this male PCOS equivalent. So can you highlight on these issues, Dr. Ashwini?
As far as the nomenclature goes, it is just a difference of syndrome and disease. Definition wise, there is a minute difference when we go through the literature of books, especially in the fertility books. But for practical purpose, PCO, PCOS, PCOD is the same. When, as sir has said, when it is so evident morphologically at times that you even need not investigate further to just to label that girl as a PCOS case. So I won't really go behind whether it is a PCOS or PCOD. It is one and the same. Male PCOS equivalent is a very, very recent thing, I would say, where there are early changes seen sometimes in the prepubertal age as well, related to the hair growth pattern and acne and all. But I don't have any personal experience related to the male PCOS equivalent. I have gone through just in the literature, but I haven't come across anything in practically in my clinic.
Okay, thank you very much. Dr. Uday Phadke, do you want to comment on this male PCOS
This
part?
male pattern PCOS or male equivalent of PCOS is just a entity which is being debated, but it is seen to be something which is genetic and which is transmitted across generations, and chiefly presents as androgenic alopecia as the chief important form. And what is funny is that in these people, the testosterone level is actually often found to be slightly subnormal than other people. Now, what exactly is the significance of this male pattern, or I'm sorry, the male equivalent of PCOS is still not 100% clear, and how it is to be treated also is not 100% clear. We often see people who are being treated with anti-androgens for this so-called young people with a balding type of pattern. They are on anti-androgens, and it's important to remember that all of these anti-androgens cause severe loss of potency and libido in men. So that's the only thing I want to caution my dermat friends about, that these can be seriously important things. It also causes gynecomastia. So this male equivalent pattern, or whatever you call it, is still an entity which is being debated and what its significance is. But I just want to say that using anti-androgens in these kind of people should be with a lot of counseling of these people and whether they really want to go in for these drugs at the cost of loss of libido or impotence, or gynecomastia.
Of late, actually, in my practice, what I've observed is that there are many male patients in their, say, 30s, 35 plus. They do come with adult onset acne, which was not so common, or we were missing it in the past. So are we probably dealing with this kind of a scenario where they have this male PCOS equivalent? And are we justified in treating these patients with anti-androgens? Because most of the times what we find is that the conventional anti-acne therapy doesn't work in these patients as it doesn't work in females.
It is believed that most of these people are actually driven by high levels of insulin and insulin resistance. So rather than anti-androgens, it could be something which the insulin sensitizers like metformin, reducing weight, improving the waist hip circumference, improving body fat, and therefore trying to reduce the insulin resistance might actually work better. Now, we still don't know. The other thing that is supposed to be active in these people is the reduced sex hormone binding globulin, which again is a surrogate for insulin resistance only. The moment you reduce hyperinsulinemia, SHBG goes up, testosterone binds to SHBG and reduces free activity. So I would think that in these people, weight reduction, lifestyle, metformin could be three important things to try out. The people that you just talked about.
Yeah, so instead of starting with anti-androgens, metformin would be a good option for these patients. And this is what is a supportive article for male PCOS equivalent. And as Dr. Fadke mentioned, it is the early onset male pattern baldness. And second thing that this article mentions is it is patients who are younger than 35 years of age and those who give a positive family history of PCOS in their mother. These are the people who probably fall into this category of a male PCOS equivalent. So now let us move on to the next scenario. I would like to direct this question to Dr. Vasudha. So Vasudha, do you find that there are ladies who have normal menstrual cycle and still they have a morphology suggestive of PCOS in your practice? And do you find that few of these women whom we suspect that the androgen is more and they still conceive normally? So do you see these different kinds of presentation in your practice when you're seeing the patients in OPD? Dr. Vasudha.
Because there are different phenotypes of PCOS, as Sir and even Dr. Ashwini mentioned. So there could be different components. Like we all know, according to the Rotterdam criteria, there are 3 components, but all of them may not be present, and she could still have PCOS. So there are women who have a normal ovulation. So obviously, if these women have normal ovulation, they might be obviously menstruating normally as well, and they will conceive also. But they might be having hyperandrogenism or cutaneous hyperandrogenism, hyperandrogenemia, and of course they could be having, this possibility is there. So there are different phenotypes that we come across. So this sort of picture is very, very common. We have women who come to us with adult onset acne. They have had a proper obstetric history. They have conceived and they have regular menses as well. So yes, I totally agree with this. And she would still have PCOS.
Yeah, so remember that normal menses does not rule out PCOS, and even if the lady has conceived normally, still she can be a PCOS clinically with signs suggestive of excessive androgen, acne, hirsutism, female pattern baldness, or maybe a combination of all these things. So coming to the next scenario now, do you find that this ongoing pandemic, we are saying that everything is online, schools are online, and do you find that there are increasing number of young patients, the prepubertal children, are they presenting to your clinics with this kind of hyperandrogenism like picture? Are we seeing increasing number of patients these days because of the changing lifestyle? And what are the points that would help us in early diagnosis of these patients? Because I feel that if you handle them at a very young age and maybe motivate them to be in a proper routine, then maybe we are probably able to reduce the other consequences in these patients. So what are your views on this? I would like Dr. Ashwini and Dr. Uday Phadke to comment on this. Dr. Ashwini?
Yes, so but the answer to the first question, what is the age group? Age group is very variable. It starts from the pre-pubertal age of around as early as around 9, 10. So pre-pubertal age of say around 9 to 13, then the pubertal age, and even further that. So age group is in early 20s to late 30s to late 40s, it's there. Increasing number of patients in pre-pubertal age, yes, it has been seen. Considering the pandemic situation when everybody is at home, everybody is sitting, everybody is busy, everybody was busy in making various recipes and putting them online and eating and sitting, which has resulted into a lot of mismatch of activity and weight. So definitely it has led to the lifestyle change, weight gain, and this has led to the hormonal changes leading to the hyperandrogenism. So yes, pandemic has been seen to have an impact on these cases. As far as history is concerned, we have to go through the actual lifestyle through which the patient or the girl goes. That what is her routine? Is she little bit active? Is she exercising? Is she at least walking or doing some home exercises? As Maitri had mentioned, that basic exercise like Surya Namaskar helps a lot if you are regular with it at home. Similarly, in the history, in my presentation, I told that there are a lot of things related to the family history as well. So, family history of diabetes, established insulin resistance is something which can be an indicator that okay, are we looking at any hyperandrogenism in an early stage, and do we need to intervene at an early stage?
Do you have any comments, Dr. Uday Phadke, on this?
So we are seeing a lot of girls with PCOS nowadays. And what is even frightening is that apart from the menstrual irregularity and the hirsutism, which can be managed, many of them have very low levels of HDL, high levels of triglyceride, even at the age of 11 and 12. And their A1Cs are borderline. They may not be diabetic yet, but they are basically sitting on the tip of a volcano, erupting anytime. And invariably, we now find that these people go on to develop diabetes in their early youth, so maybe around 25, 30. The other fact which we are seeing very, very commonly is the presence of fatty liver disease. Not just fatty liver, but significant enzyme elevation causing what we call steatosis. And you know that in the US now, with the registries actually showing us that the commonest cause of chronic liver failure requiring transplantation now is NASH. So you can imagine if that there is a chronic liver inflammation from the age of 15, it is bound to result in something catastrophic by the age of 40 or 50. So these things are very common. The second important thing is that it might, and when I first read about it, I thought it is, how can it be? But you know that children, so girl children who are hirsute, often tend to have a father who has excessive body hair. So first I thought, what is the relationship between the two? I mean, this is a completely separate illness, but it appears that tendency to have more body hair, not just lanugo hair, but actual hirsutism increases if the father has more body hair. That's number two. And the last thing that I would like to caution everyone in this program is, we sometimes are referred females who have finished their childbearing, have 2 children, went through pregnancies uneventfully, they conceived naturally, had normal periods, and now they have started getting hirsutism, irregular periods, acne, say at the age of 35, 40. Please do not label these women as PCOS unless they are thoroughly investigated, because what you're typically dealing probably in these are secondary causes of all these disorders like an adrenal or ovarian tumor. So it's very unlikely for PCOS to start de novo at this age. Of course, it can come, We know that PCOS can even come in post-menopausal women, but then it should not be labeled as PCOS unless it has been worked up. So age of presentation is very important. Yes, we do see a lot now coming very early, and one of the most important reasons is that they are terribly overweight and that they are terribly insulin resistant. So one needs to start right at that age for weight reduction, lifestyle, exercise, etc.
Okay. And regarding this insulin resistance, often like we dermatologists advise them sugars and of course insulin levels, and we find that the fasting insulin is normal, but the PP insulin is many of these patients is high. So does it really have any significance? And
At the cost of appearing rude, and don't mind me saying this, do people who advise this, have you read anywhere that this is advised? Or is this by kind of common sense or by hearsay? Can some people comment on this? Because nowhere is it recommended to do all this. I wonder where this comes from. And I have had so many discussions with Dr. Avanti Golwilkar or Dr. Manisha, and they get so many samples, and then they have now started this IRS2 without even knowing any kind of normative data for Indians. So let me repeat, doing a insulin level is pointless. If you have features like obesity, insulin resistant, if you have irregular periods, you can assume that there is insulin resistance. You don't need to do, if you have elevated triglycerides, if you have low HDL, if you have hirsutism, you can take it for granted. The only place for doing insulin levels is if you're dealing with what we call Heran syndrome, which is a state of extreme insulin resistance where there might be something different, but those are different disorders. Or if you're in a clinical trial. But otherwise, insulin level doesn't tell you anything, honestly. It has no meaning whatsoever. So don't do it. People don't even realize that when you measure serum insulin, you're measuring insulin, pro-insulin, all kinds of other things. Insulin levels are always taken in conjunction with blood sugar levels. So just that one value in a range doesn't mean anything. So I would not advise insulin levels.
in short, if there is a clinical evidence, we go by clinical examination rather than doing the test and treating the lab.
Because it doesn't help you in changing your management at all in one bit also.
Yeah. But is it like if we do it, it is easier for the patients to take it? Like, I mean, because if you tell them to take, say, metformin to a young girl of 15, the parents go to the chemist and the chemist tells them that doctor ne tumhala diabetes चा औषध दिलं आणि तुमच्या मुलीला तर diabetes
That is
नाही.
our job to explain to the patient, right? And do you mean to imply that people are not recommending metformin when the insulin levels are normal? They are.
Yeah.
So doing the insulin level per se doesn't hold any water for me at least.
Okay.
I may have a little strong views on this, but
Yes, so like actually this is what we want, because we are like, when we see these patients, we always offer a list of investigations, and I think half of the investigations are absolutely not necessary. That is what we learned today from all these talks that you have given. So Dr. Ashwini, any points in clinical examination or history taking where we can pick up these girls very early?
In the history taking, as I said, you can ask about the history of weight gain and whether there is a history of any rapid weight gain happening more over the waist and the hip. So there is something called as waist hip ratio. If scientifically, if we have to measure the waist measurement in inches or centimeter, and then we have to take the waist hip ratio and we have to see whether it is increasing gradually. So that is going to indicate the fat distribution happening around the waist, which is again a clinical parameter for PCOS. For hyperandrogenism, when we examine the distribution of the hair pattern, we can see the pubic hair development, we can see in prepubertal age, Sometimes the mothers are bringing the young girls at the age of 9.5 or 10, looking at the development of the pubic hair. So it becomes a good habit to examine clinically, so that it helps for the counseling of the patient that, okay, probably she is showing very, very early signs, and then they need to take the lifestyle modification very seriously to avoid the medications.
Yeah, thank you. So let us move on to the next scenario, and this was actually discussed by Dr. Fadke, the solitary presentations, like patients presenting with only one particular cutaneous manifestation, either hirsutism, female pattern, or this persistent or true adult acne. Now the question is, they definitely would come with these features to a dermatologist. So should we be trying our dermatologic treatment as a first line, wait for a few months and then put them on hormonal therapy, or we straight away combine both the treatment options? So that is always a dilemma, and especially so when we are dealing with the patients who have this acne problem, which is persistent, even like when they are 25, 30, 35, 40, it just goes on, and they are frustrated because you have given them all the antibiotics, they have taken practically isotretinoin peels, everything is given, and still the response is not there. So how do you approach these patients? First, I would like to know this from Dr. Vasudha, and then we will take inputs from our friends. So Vasudha, how do you manage these patients? Biochemically, if you see, they are normal, only the clinical and a solitary presentation, and acne is something which bothers us a lot.
Right. So you already mentioned that biochemically they are normoandrogenic, but they do have signs of cutaneous hyperandrogenism. So that could be because of the increased responsiveness of the end organ receptors, or probably, and particularly this girl in the center, she's got obviously female pattern baldness. So maybe an increased 5-alpha reductase activity. So we would be justified in starting her at least on a topical 5-alpha reductase inhibitor. I'm sure that can be justified without directly jumping into a systemic treatment for this girl. Second one would be, I mean, the girl with hirsutism. So in her case, also there is obvious evidence of, local, at least cutaneous hyperandrogenism. So we can start her on maybe a spironolactone. And we know that already Dr. Ashwini mentioned that for hirsutism, ethylene estradiol combination with either cyproterol acetate, or you can even start her on different, just spironolactone. So that is what I normally do, even without, if they are normoandrogenic, along with laser, I already start them on spironolactone or cyproterol acetate in combination with ethylene estradiol. And coming to the third girl, now she has got severe acne. So in her case, she's obviously a young girl, so maybe she's not yet married looking, I mean, that part has not been mentioned, but she's not married, but she might plan to marry. But in case she has still got time on hand, so I would like to give her first a topical or obviously an antibiotic along with a systemic antibiotic. Now, roxithromycin is something which is not used much by us, so there are less chances of resistance. And I've also seen in my practice as well as read that roxithromycin also has got some anti-androgenic property as well. So I would start her on roxithro or amoxicillin, and along with that, initially after maintaining or rather managing the inflammatory part, start her on isotretinoin. If she does not respond, then I would add some anti-androgenic in the third girl with acne. So that would be my line of management for these three cases.
So actually, I want to know from Dr. Varsha, you do a lot of procedures, Varsha, you have lasers and other things. So before putting these patients on hormonal therapy, do you want to support them by using treatments like, say, chemical peels, or maybe say a Q-switched NDR laser, or maybe some topical therapies that you can add in your treatment, like a slush or something like that?
Yes, ma'am. According, like the third girl with acne, she's having, we can say it is grade 2, grade 3 acne. So there is a lot of inflammatory component. And I've been using a lot of IPL in these patients right away. So along with the medical line of treatment, we can definitely add on IPL sittings, which take care of the inflammatory and the post acne erythema that occurs in these patients. So definitely IPL I can add.
So do you feel
May I
that these
ask what IPL is? What is IPL?
IPL is intense pulse light actually. It is a light-based device. Varsha, you can elaborate on it if you want.
Sir, actually, it is intense pulse light therapy. So in this, we have a range of wavelengths. So it can take care of right from 440 nanometers of wavelength up to 1200 nanometers. Whereas the other lasers, so IPL is basically a light device, whereas other lasers, they are specific with the wavelength. Like Q switch will have 1064 nanometers of wavelength, but in IPL we have a range of wavelengths. So it takes care of along with like a specific component of acne, even other components are taken care of. So it is quite useful.
And also, if you use a Q switch laser by applying a carbon solution and you put it in a kind of a genesis or a spectra mode, that causes heating up of this carbon particles, and that reduces the burden of P acne. So ultimately, it helps in reducing the inflammation in these patients, and is kind of a useful adjuvant to our medical line of therapy. So Varsha, do you think that using this supportive line of treatment, the burden of pills, like the use of antibiotics, can we minimize it in these patients? Because if you see, like you give doxycycline, you give it for 2 months, 3 months, you taper it, stop it, and it flares again. So by adding this, can we achieve this actually?
Yes, ma'am, definitely. If we counsel the patient properly, we can start the laser therapy right away. So the duration of the antibiotic required is also less, and plus the post inflammatory what we can say, the scarring and all that also reduces quite a lot.
So do you think that by combining these two modalities, we are able to kind of delay the addition of hormonal therapies to these patients? Is it your experience, like if you combine your laser light-based therapies or maybe a chemical peel along with a short course of doxy or minocycline, you sometimes don't need any hormonal therapy in a patient who is biochemically normal? What is your experience?
Yes, we can do that, but then the recurrence rate will be more if she has that underlying hyperandrogenism. In that case, definitely we'll have to switch over.
So when do you do that? Like, do you do it right in the beginning, or you wait for 3, 6 months, 1 year to see whether your treatment is working or not, and then add it?
It is only in treatment resistant cases when we have relapses after tapering isotretinoin and antibiotics. If we have relapses in these patients, we can think of adding anti-androgens in the form of spironolactone.
So I think that is important, that is treatment resistance, because there is always a chance that a good number of these patients would respond to your supportive therapy, and maybe you will be able to delay the addition of anti-androgen therapy to these. So resistant cases is what I think we should think of using the hormonal therapy. Do you want to add anything, Dr. Uday Phadke or Dr. Ashwini?
No.
You agree to this, like not as a first line.
Normal, then there is no role of pills. If she her
No role.
Okay, then there
But
is.
but I think female pattern, we have to take help of finasteride. If the family is complete or if the girl is not married, then these are the cases where only the topicals do not work. That is what is our experience. So do you agree to this, Dr. Vasudha?
Yes, ma'am. As I said,
yeah,
they are all of marriageable age, and they might be reluctant to start on 5-alpha reductase inhibitors in the oral form. So we can try topical, but we all know that topical ones really don't work as monotherapy along with minoxidil. Yes, if she has time on hand, we can start her on finasteride or dutasteride, and we can try out. But then, as we said, she has to be very, very careful and cautious regarding contraception.
And regarding these hirsutism cases, if they are biochemically normal, I want to know from Dr. Uday Phadke, like, can they be managed only on the laser therapy?
Yeah, so that's a very important question. And that is a discussion which I have with each and every patient as to what is their aim in life, honestly. If the aim is purely cosmetic and we really cannot find either a metabolic abnormality or something which is reversible, I think anti-androgens might still help, because ultimately if they have hirsutism, it does mean that they have some hyperandrogenic nature. But if they have limited areas of hirsutism, then I do counsel them purely about cosmetic therapy.
Yeah.
Without any
So,
medications.
Yeah, and the results are also quite rewarding in most of the patients with the cosmetic therapy. Only few will be just kind of a poor responders, or they won't respond at all to your laser therapy. But the number of such patients is much less as compared to those who respond to the laser therapy. So it is worthwhile trying it. What I do is that, yeah.
Sorry to interrupt. Yeah, so we had a lot of patients whom we tried, or rather we routinely do long pulse Nd:YAG laser, and we found that many of these idiopathic, so-called idiopathic hirsutism cases, they also require some form of anti-androgen later on. We do give them a trial of say 3 months, 6 months, but the hair thickness, the hair-free interval, somehow it just refuses to reduce. So these cases, we end up putting them on oral anti-androgens, because they don't
So
do well.
those who are resistant to your therapy, only in
For
those
6
patients,
months.
yeah. So at least the 3 to 4 sessions you have to do before you label them that they are not responders, because at the end of 3 sessions we find that at least 50% of the thick hair growth, that is the terminal hair growth, decreases, and then in that case you can continue with your laser treatment. Another question that the parents ask is that what is the ideal age when we should start the laser therapy? Because nowadays there are girls, maybe a 9-year-old, she comes with a hirsutism, she has upper lip mustache, and she is in a co-ed school, and the boys keep on taunting the girls. So parents don't want to go for threading, waxing, and they want to know like whether they can offer this laser treatment to a young girl who is 8 years, 9 years. So what is your take on this? Is age a bar for starting the treatment? Laser treatment I'm talking about. Barisha, do you want to answer this?
Ma'am, age is actually not a bar. We can start away the laser therapy as early as possible.
Yeah, so age is
Can
no bar.
Can I ask something, Dhanashree?
Yes.
I mean, why would an 8-year-old girl develop terminal hair on the lip? I mean, what's the mechanism?
That is what, no, we are seeing like these young girls now, they have this sign, and we are seeing girls of 9 years, 10 years who have acne. Some of them have started developing hirsutism also. So probably this is a early onset, I would say a PCOS girl who is coming, and we have to like think beyond only the cosmetic treatment for these girls also. Like Ashwini was telling us that young girls are also now presenting. So probably we need to evaluate them more in details and keep them on a long-term follow-up. But
so my caution here only is that when you get girls like this in the pre-pubertal age group with virilization, do keep congenital
adrenal hyperplasia,
virilizing adrenal hyperplasia, late onset in mind. Treatment, of course, is different, but
I think these extremes of ages, when it is for the first time, like the pre-pubertal as well as peri and post-menopausal, there we have to be cautious regarding the adrenal hyperplasia and also the tumors. So I think these are the ages where the investigations should be more in details rather than when we are dealing with a typical pubertal and post-pubertal girls. So do you agree to this?
And many of them also have insulin resistance. These young girls at the age of 8 or 9, they end up having very early menarche. They also have a Tanner maturity reading of say 2 or 3 at a very young age. And they also have acanthosis nigricans, etc., which shows that they have insulin resistance, and that could be the hair growth of the hirsutism could be part and parcel of that because of the weight
then
gain.
what should be the strategy regarding the investigations? Because we have to rule out these causes, right? So should we investigate or should we not investigate these girls?
Sir would say not investigate, except for congenital adrenal hyperplasia, I think, based on what he just told us. So, sir, what would you think about this? Because our line of management generally is to, focus on ruling out insulin resistance and CAH. But what do you think we should do?
CAH, I would certainly like to rule out because that's very important. See, just insulin resistance is present in maybe 50-60% of the population in India, or more maybe. How many of these girls are hirsute? Not necessarily so. They may have other features. So for insulin resistance alone to cause hirsutism, you need something like a extreme insulin resistance like we see in Heron syndrome, where the only pathogenetic abnormality is insulin resistance. Otherwise, insulin resistance is part of the whole syndrome. Somehow it is hyped up to start believing that it is just the insulin resistance which is causing hirsutism. No, it doesn't happen that way. It is an association. But what I would like to rule out, as in the scenario that you described, is adrenal hyperplasia, no doubt. There's just one thing which I would like to say. It's of course not to do with your branch because you know the difference. But I get a lot of people coming to me with so-called hirsutism, and they don't actually have hirsutism. They just have increased body hair or hypertrichosis. And they've been frightened into thinking that, there is something majorly wrong. So I think that also becomes a very important counseling issue to tell them the difference between the two and explain that treatment may not be necessary, because some of them have even undergone lasers at some cosmetic parlors, not dermatologists. So and it doesn't work, obviously. It in fact sometimes causes worsening. So this is a point that certainly would need address.
Attention, yes. So now these two extreme presentations, the very minimal hirsutism, very mild acne, as against very severe hirsutism. So this was actually discussed. I will not repeat what was discussed, but now these scenarios, like this was a young girl, 15 years old, menarche at the age of 11 years. First 2 years, the cycle was a little delayed, 45 days cycle, and now the cycle has become pretty much regular. Sudden onset of acne after the 10th standard exam. So last 8 months or so, she was having this problem. Few inflammatory lesions, no comedone. So obviously it is a mild acne. The distribution, if you look at it, it is a lower jaw and a chin type of distribution, which we normally see in patients who have androgen excess type. Premenstrual flare again is a pointer, and she is a treatment naive patient, so she has not taken any treatment. And as against this, another patient, again a 18-year-old. Now with this girl, the menses are totally irregular. She is getting only 3 times in a year, the menses, and once she gets a menses, the bleeding is for almost 15 days every time she has it. And what has happened in this patient is that she has gained about 20 kgs in last 8 months. So sudden weight gain is something what is noticeable in this patient. And if you see the grade of hirsutism, the grade of acne is, we would say it is moderate to severe grade of acne. Now, investigation part we will skip because Dr. Fadke has clearly mentioned that investigations, if in a setting where the cutaneous features are already there, you may not investigate these patients. So the time of investigations, etc., also doesn't come. But just in case if we decide to investigate a particular patient, I would like to know from Dr. Ashwini, when should we investigate them? So the follicular phase, the luteal phase, the morning sample, because there are so many things that the lab people are going to ask you. And then a person who has amenorrhea, like the girl, second patient, she did not have her menses for, she gets it only 3 times. So how do you induce menses and do the test, or what is the strategy? And about sonography, we tell them that sonography may not be done, but sometimes the mothers themselves take the patients for sonography. So how should we counsel them? Like at what age it is recommended or it is not recommended at all? Then the criteria you have already mentioned, so we need not discuss that again. And in a resource poor setting, like if we decide to investigate and a person is completely non-affording, what is the minimum possible investigations that we can advise to these patients? So I would like to know this from you, Dr. Ashwini.
Okay. Now, as sir has said, Not a list of hormonal investigations are required now, especially in these two girls when they are 15 and 18, and there is no question of contraception or fertility. So ideal time for investigations for all these patients is always in a follicular phase, especially in the early follicular phase, if you want to complete the list of PCOD investigation just for the sake of completion. Or sometimes you need to counsel the mothers that how the LH FSH has a role in PCOS. They have read it on Google that okay, the LH is high, the LH is double the FSH, and for that sake if you want to do the investigations. Otherwise in follicular phase the baseline levels of the hormonal milieu is always there for all the hormones which have got an estrogenic effect. So we suggest the test be done on day 2 or day 3 of the menstrual cycle, especially morning sample, empty stomach. The investigations are important are serum prolactin and thyroid function test, as sir has mentioned in his talk, that these two things are going to tell us, okay, are we looking at something else other than PCOD? Now, if she comes with an irregular cycles, if she says that she hasn't got her periods for last 50 days, don't rush for the investigations, because per se delaying of the cycle in the luteal phase, physiologically also sometimes the prolactin levels are seem to be high. Or if she has taken any medications, the prolactin levels can be high. So induce the menses with the use of progesterone. Usually medroxyprogesterone is supposed to be safe. Even norethestone can be used to induce the menses for 5 to 7 days. So give the medicines to 5 to 7 days. Sometimes I have seen the prescription of giving the progesterone for 3 days, and then the patients still don't get the menses, because these patients are very, very resistant even for a progesterone withdrawal. So they would need a good course of progesterone for good 7 days and adequate in dose, not something like 5 milligram. Or some the people dermatologists especially have seen to keep it on the lower possible side. So the dose required as per the weight of the patients is around 10 milligram per day. Very rarely 20 milligram for those who are 95 kg, 100 kg, 110 kg, like that. But otherwise 10 kg per day for 7 days is a required progesterone dose to induce the progesterone withdrawal bleeding. And then you do the investigations. Sonography, somehow patients have a fascination for sonography than us as a clinician. We do tell them that there is no need, but most of the patient will come with a fear that if you ask them, okay, what is the problem with you? They will tell you, doctor, I have got PCOS. That's why I'm with you. Because they have already done a sonography and seen that, okay, the radiologist has mentioned that there is PCOS. Ideally, at least till the age of 20, there is no role of a sonography, whether it is a transabdominal or a transvaginal. But if at all it is to be done, and if the girl is sexually active, then transvaginal is recommended because of the clear vigilance of the ovary. Usually these girls have a higher obesity, central obesity. So the visualization of the ovary becomes difficult. Measurement of the follicle becomes difficult. And what is particularly seen as a sonographic picture in the PCOD ovaries is the hyperechogenic central stroma. So that is better seen with a transvaginal ultrasound. But to answer to your question related to these two cases, there is no need of sonography. And in resources poor settings or non-affording patient, I think your counseling should work in such a way that these two girls don't need any investigation, and you can directly start them with a combination therapy.
Yeah. So young girls below 20, investigations, you can keep them on hold, counsel them, or treat them. And if they are treatment resistant, then maybe you can think of investigating. And the investigations are more directed for the other causes, like maybe a thyroid dysfunction or something which is affecting that, and prolactin levels. Yeah. So that is what we should actually be doing for these patients, young girls who are not married and less than 20 years.
I tend to do the OGCT also for these girls, because I know that I'm going to start them on a pill, especially for the girls who are 18 and above, not the girl of age 15. So usually I do an HbA1c and OGCT for these.
Okay. So that is
I have
another
just
thing.
one small point to make, if I may.
Yeah, please.
Slight contradiction to what Dr. Ashwini said. In these people with irregular cycles in PCOD, there is nothing like a follicular phase and a luteal phase. So you don't really need to wait. You can do the investigations anytime. What are you trying to investigate is what you have to actually understand. What I'm trying to look for in a person with very long cycles is whether this person has premature ovarian insufficiency. That is what I want to do by doing a FSH. So whether the FSH is 3 and LH is 17, I'm not really concerned, honestly. What I want to know is she going into premature ovarian failure, and that's why she has amenorrhea. So whether I do it in the luteal phase or in the so-called follicular phase, there is no follicular phase in a person who is non-ovulating. So I personally do not induce periods. If I want to test, I do it on that day. So if they tell me I've had my last menses 3 months ago, I say, fine, you do the test today. It doesn't matter. It gives me the answer that I'm trying to get. What are we dealing with? As I said, the investigations are only to rule out other things. To diagnose PCOD, they are meaningless as it is. So if I see a non-elevated FSH, I get my answer. If I see a prolactin which is not too high, I get my answer. If I see a TSH which is not too high, I get my answer. That's it. That's what I'm seeing. So I don't need a ovulation, induction of menses.
And what about this test, the anti-Mullerian hormone test, like the ovarian filter? So is it a more sensitive and that should be done, or should we be going ahead with this?
So again, no, see, again, what are we looking at is important. If you're looking at a person with prolonged amenorrhea and you're trying to look at ovarian reserve, say no periods for say 4 months, 5 months, 6 months, and you want to see, AMH is a good test. AMH is also independent of time of menses. So if the AMH, in fact in PCOS, because of the multiple follicles or the multiple unripe follicles, AMH often tends to be high. So if I see that the AMH is not low, then I know that this person is not in ovarian failure. That's all I know. Otherwise, AMH cannot diagnose PCOS. So that's the only importance of doing a AMH.
So to know the ovarian reserve, that would be a more sensitive and a logical investigation that we can offer to a girl who is not menstruating for 4 or 5 months like that. Cycle of 45 days, cycle of 35 days should not be a point of concern.
Not
but
really
like in our second patient, she is menstruating only 2 or 3 times a year. So in that case, maybe we would definitely.
So there is another way of how we look at AMH. Nowadays, we get people, say, between the ages of 30, 35 also, married recently. Often marriages happen late, and they have not necessarily decided about pregnancy because of their careers and so on. Sometimes we now find that AMH tends to be lower nowadays for a variety of reasons. Perhaps Ashwini might elaborate. But if the AMH has started to drop a bit, we actively tell them to pursue their fertility earlier rather than later. You may correct me if I'm wrong here, Dr. Ashwini.
That is the right observation. That is the right observation. That surprisingly very low AMHs have been seen in a very early comparatively, like 28, 30, 32, and you are seeing AMH of 0.5 and 0.6.
So we tell them to finish their obstetric career a little quickly rather than delay.
Yeah. So these are some of the results of a laser treatment, because this one was not put on any hormonal therapy, but she got good results in 3 to 4 sessions. Now, this point was there in Maitrey's talk, the lean versus obese PCOS. So you can see that both of them had signs of androgen excess as far as the clinical examination is concerned. One is obviously thin and the other one is really obese. Now, the point here is that, like, when we tell them to follow a particular exercise and a diet routine, especially in a lean PCOS patient, it is very challenging because patient says that I'm already thin and if I exercise, I will lose my weight. So how do we tell them and what we should tell them so that they pursue this particular diet and and exercise plan. And second challenge with the obese ladies is that you tell them to do everything. They are religiously following what you tell them, but the obesity is kind of resistant, so they don't lose weight at all because probably the metabolism is slow, and they want to know how to improve the metabolism. So in both cases there are difficulties in and challenges as far as the diet and exercise routine is concerned. So how do you counsel these patients, and what we should be telling both the groups of patients? And the role of anti-obesity medicines also. Some of them are going to ask you, can I go and visit an obesity specialist? Then the bariatric surgery, and so many issues are there with these girls because they are depressed also because of their appearance, because of the way they look, and they are not visiting any places. So many other things are involved in these patients. So how do we go about these patients? What do you want to address this?
That's a
Varsha,
tough one. Oh, sorry. Sorry.
So
Sorry.
you can go ahead. Sir.
No. Please.
I
I would be happy not to answer this at all.
You will be the final authority, like final comment by you. Varsha will tell us about the diet and other things.
Okay, ma'am, actually, when you're dealing with patients who want a diet plan, it is very difficult to counsel. It is easier to give a prescription rather than giving a diet plan. That is because we actually, just as you said, they're low on their morale, and we need to do a lot of boosting. And plus, we have to educate the patient regarding the diet. As in the like Maitri has already told, that we have to educate the patient regarding what are the dietary components in the, like, in our everyday diet. So where we have to cut down. Now, as you see in the first patient, one is the lean PCOS patient. Now here, most of the times the mother is worried because they don't want to do any caloric restriction, because already they say the weight is low. So how will we, cut down the calories? But if we see in lean and obese PCOS, both of them, they have insulin resistance. So what we have to cut down is, we have to cut down the quality wise calories, and plus the main aim is to give high protein diet, as we have seen in the first presentation also. So giving a high protein diet is the clue, and here is where we have to educate the patient. And most of the times, because of in both the cases, these patients have a lot of sugar cravings, and they to substitute their obesity, or maybe to increase the weight in lean ones, they generally they go on eating unwanted calories. So here is where the counseling helps. So first is when a patient comes to us, like especially for the diet plan, what I do is I find out the ideal body weight depending on the height of the patient, and then we take the parameters like the waist and hip ratio. So we actually grade the obesity. There are 3 grades what we can, depending on the body mass index. So accordingly, we know how many calories have to be cut down. So if the obesity is of a severe type, we have to literally cut down the calories by depending on the recommended allowance. We have to cut down almost to by 500 calories we have to reduce from the actual required calories for the day. And whatever the remaining calories we have to give, the sources are important. So here we use a lot of proteins. That means in every meal there has to be some protein component. Now protein, basically, as explained before, it gives a lot of satiety value. And secondly, what happens, the sugar spikes that we get after the meal, they are very less. So the continuous like you have the spikes and crashes that we have generally when you have a cereal based diet, that is not seen in high protein diet. So I would suggest that.
Can I interrupt you for a minute?
Yes, ma'am. Yes, ma'am.
See, it's protein, and then we talk about calories. That patients don't understand anything like that. 1200 calories, 1500 calories. They don't understand. You tell them you take 1 gram protein, 2 gram protein. So practically, how do you tell them? Like, you tell us the items, like. So now Maitri was talking about the lentils and other things, and they are the sources of complex carbohydrates. And many patients think that when they are eating these usar kind kind of a thing, that is a source of protein. So how do you tell them like so much amount of protein you should, because you tell them 50 grams, 100 grams measuring, they don't have time. So what is the simplest way to tell them how to eat it?
First, we have to take the diet. Actually, we have to take the diet
That
history
you
of the
have done,
patient.
like you tell me like the proteins, you eat these proteins and you eat it this way. Like don't tell us about how, like what 1500, well, not like that. Practically,
Right.
what do you tell your patients?
Right. Ma'am, most of the times what happens, if you ask the patient history, they will explain, I have दोन चपाती भाजी उसळ mostly नसते, and they take lot of thin dal. म्हणजे भात वरण घेतात, पण वरणाचं जे
Is it a
consistency
protein
आहे,
or a
that
complex
is
carbohydrate? That is a confusion now, because she said all these lentils and beans are now sources of complex carbohydrate.
right,
So do
right.
they
So that is where I was coming. So normal, our Indian diet is composed of this, like we said, chapati, bhaji, and bhat and varan. So if you see, the protein content of our everyday diet is anyways low. So here what we will say is एक वाटी दही, जे तिने आधी सांगितलं की ते घ्यायला हवं. So you start with protein. Along with that, the size of the chapati that we take should be very small. So it should be medium size chapati. आणि त्याच्याबरोबर we have to take एक वाटी घट्ट वरण, which is again a second protein source that we are talking about, and a lot of vegetables. So in vegetables, we have to take raw as well as cooked vegetable. So त्या एका चपाती सोबत we have to finish 1 vati of ghatta varan with 1 vati of raw salad with 1 vati of green leafy vegetable or any vegetable of choice. And here we have to cut down on rice, so that will keep the carbohydrates to the lowest. And what we are giving is complex carbohydrates, that is those which are not easily digestible. So the amount of sugar that goes in the blood is also like it is
what
in a slow
about
process.
Sprouts, is it a source of protein?
Yes, if we see the sources of proteins, pulses, legumes, and dals, and also sprouts, they are actually poor sources of proteins, you can say, if you compare for a vegetarian diet. But since vegetarians do not have any option, what they can do is they can combine this protein source with a little bit of carbohydrate, that is grains. म्हणजे भाजणीचं पीठ is a very good quality wise protein is good, because if you see, pulses lack in one essential amino acid, that is methionine, whereas carbohydrates, they lack in one amino acid, that is lysine. So if you mix them together, it is like a lock and key thing. So if you have both the things together by keeping the carbs less, that is keeping the grains less, then we can get a very good quality of protein in a vegetarian source.
So
But
now
then
let us hear from Dr. Uday Phadke. What is his final comment on this? Like how should we plan? How should we treat these patients, and should they be obese once?
We use a simple thing to show the lean PCOS. So the proportion of lean PCOS, of course, is less than obese PCOS. But interestingly, the proportion of body fat in lean PCOS and obese PCOS is high. So even if their weight is low, the percentage body fat is high. So there are many methods using these impedance measurements. You can just stand on them and they give you a body composition. You will see that the body fat percentage is quite high. And that is quite convincing to patients to actually start using diets. Another important thing is that use of oral contraceptive pills, as we discussed today, with say drospirenone and ethinyl estradiol, actually changes body fat percentage in these lean PCOS. So we use these composition analysis to show them where things are wrong. So their overall weight may be low, but their body fat percentage is high. That is what we show them to motivate them further.
Yeah. Okay, so this is what we have already discussed. Now coming to the age group wise patient scenarios, like pre-pubertal, puberty to marriage, marriage to childbearing, post-childbearing, and the risks involved in each type. Like when a pubertal girl comes, the parents and everyone is worried about the fertility of that girl. Then later on, it is the malignancy risk that we are worried about. Pregnancy time, it is a abnormal glucose tolerance, that is the gestational diabetes we are worried about. So do we plan anything in particular in a particular age group so as to avoid or delay all these risks, or maybe if at all they get it, we can diagnose them early? So what should be the strategy? So do they need regular investigations and follow-ups, or do they need only a regular clinical examination? Because if I ask Dr. Uday Phadke, he will insist on a clinical rather than a biochemical thing. So how do we approach these patients?
Can I say?
Yeah, please.
Sure. So in pubertal age groups, particularly if we have patients presenting typically only with irregular cycles, a little bit of obesity, signs of insulin resistance, without much hyperandrogenism, they are best managed with monthly progesterone plus minus metformin. And that gives them regular cycles and, of course, lifestyle counseling. And that keeps them going right till the age of, say, a marriageable age. This is of people who do not have significant hirsutism or acne. Okay. At the age of marriage, we convert them onto oral contraceptive pills for contraception and ensuring very regular cycles so that they don't conceive and can then plan their pregnancy with their partner. And when they plan their pregnancy, we refer them for induction of fertility with whatever medicines are necessary and available. This is typically what we do. Often pregnancy itself will ensure normal cycles for the next few years because of the nature of the hormone changes in pregnancy. And then if the problem comes back, we look at them again. So this is the typical cycle we follow in people who do not have hirsutism. For those who have mild hirsutism with normal levels of androgens, we do the same thing that I said right now and send them for cosmetic therapy so that their problem of hirsutism is tackled. But for those with significant irregular cycles with significant hirsutism, we use oral contraceptive therapies plus minus anti-androgens plus cosmetic dermatology therapy to give them, and we use it long term till they desire pregnancy or plan pregnancy.
Okay.
That's my approach to it.
From Ashwini, we would like to know what is the age group when you can start a contraceptive pill? Like if you see a girl, say, like I'll take the example of acne, a pubertal girl. Now you have treated for 1 year or so, she has not responded, and we think that she should be put on a contraceptive pill or maybe some kind of a hormonal therapy. So what should be the ideal age after which we can start a contraceptive pill? Which one is better for these patients, and what is the maximum duration for which we should be giving it at a stretch? And one more thing, when we are on a contraceptive, you talked about various risk factors and other things. And as a dermatologist, we are always worried about prescribing it and also worried about the thromboembolic episodes that are much talked about as a complication. So are there any red flags, like where we can understand that this patient is probably likely to have a thrombotic episode or thromboembolic episode? So if you get a particular symptom, you always warn your patient to come back to you immediately and stop the pill. So these are some of the practical problems that we face while prescribing OC pills. So can you comment on this?
While prescribing the oral contraceptive pills for young girls, I personally don't start oral contraceptive pills anyone who is less than 16. Above the age of 16, with a very much inflammatory acne, where they say that they have been to dermatologist, have tried local applications, still no use, and having along with that, there are irregular cycles. We know that ethinyl estradiol combinations are going to work well with inflammatory acne. So ethinyl estradiol around 30 microgram with drospirenone usually is the prescription to regularize the cycle and to control the inflammatory acne. And at the same time, we tell them you continue your procedure, your treatment with the dermatologist to have a better effect. What I've seen is correction of hormones and then simultaneous local treatment application gives a better result. Now, as far as the treatment continuation is concerned, usually everybody is skeptical about the continuation of the oral contraceptive pills for a very longer time. So if the girl is already on the higher side of the weight with a very strong family history of hyperlipidemia, of diabetes, hypertension, then we have to warn them about the lifestyle modification and spend nice 15-20 minutes with them about the lifestyle modification, because that is going to probably reduce the duration of the hormonal treatment. So at a stretch, usually we give for 6 months. We tell them to see the effect in 6 months. And if there is a reasonable effect, then maybe they can take a gap of 1 or 2 months to have a pill-free interval and then restart again. In those 1 to 2 months, usually as far as the menstrual irregularity is concerned, usually that doesn't come as a problem, because the immediate effect of the combination of ethinyl estradiol and drospirenone, which has been there for 6 months, in the 7th and 8th month, usually they get their spontaneous cycles. If they don't, then just a use of progesterone for 7 days is sufficient. But if your patient is compliance is good, if patient is ready to follow up with the side effects, there is no harm in continuing with a 6 months on, 2 to 3 months gap, again 6 months on, and simultaneously going on with the dermatological treatment. Now, the thromboembolic episode, which we all are scared of, is the basis of which lies in the history taking. So even a close family history of venous thromboembolic episode, we should explain it to the patient, and we should do the counseling related to the risk management. If the patient is ready to understand the risk, ready to work on the lifestyle modification in terms of diet, exercise, hydration, then only you should prescribe the pill. And as a part of follow-up, you should explain them about the early signs of leg pain and any leg edema that is seen. And if they come back to you, even though it is like over investigating, it is better to get them investigated for the thromboembolic episode. I have seen around 2 young girls of around age 20-22 with the beginning of the thromboembolic episode in last 15 years. And that was very initially picked up just with the complaint of leg pain.
And what about headache also?
Headache, as I said, migraine is a relative contraindication for oral contraceptive pills. So if any girl is giving a history that, okay, I'm suffering from migraine, usually the ethinyl estradiol component tend to trigger the migraine. So maybe it is better to counsel them that you are not fit for the oral contraceptive pill, and if it is a must, if there is no other alternative possible, then try to go on the lowest possible combination. But with the first onset of headache, she should be stopping the
so headache, leg pain are some of the clinical symptoms that we should be looking for, and before we start, we should explain it to the patient so that they report these complaints to us and we can take proper action
and immediately stop the therapy.
Can you tell us few trade names, because like people are always confused which is second generation, which is third, which is fourth, like that, and low estrogen, high estrogen, lot of confusion is there. So as a dermatologist, we are very fond of this diane, which is cyproterone acetate and ethinyl estradiol combination, and that works quite well also.
That works well, madam. It has got diane and Jeanette has got a combination of ethinyl estradiol of 30 microgram and cyproterone acetate of around 35 micrograms. So I think that works well.
And any other pills like
the combinations with levonorgestrel usually gives the more side effects. So don't go for those. That is what I will tell. Those were the second generation pills, which we usually use for contraception purpose, which has got an ethinyl estradiol and levonorgestrel as a combination. That doesn't work much for acne and hirsutism. What works is drospirenone and cyproterone acetate.
And you were talking about the thrombophilic phenomenon and this thing as a relative contraindication. So before prescribing a pill, should we be doing a CBC and a liver test also of these patients, or we can start if the patient has no obvious clinical history of any of these things?
For thrombophilias, it is just the history. If there is no suggestive history, there is no point in
No
investigating.
need
There
to
is
investigate. So
no need
you
to
don't need any
investigate.
investigations before you start. The
Yeah.
liver toxicity also, which we were talking about cyproteron acetate,
Yes.
which Dr.
So,
Padke mentioned in his presentation.
yeah, as sir has said, probably liver toxicity is something which is not clinically established at times. The patient might not give a clear history of jaundice, of she has, or if she has been a pregnant before, and then she might not be able to give the history of cholestatic jaundice. So doing an SGPT and SGOT would be a worthwhile.
So Vasudha, I would like to know from you, like some of these OC pills, they can cause a flare of acne. So a person who is having acne, which pills should be avoided? So can you just tell us, and which can be taken? If we
Pills,
want
as
to
in,
prescribe a OC.
yeah. So as Dr. Ashwini just mentioned, the ones which have minimum androgenic action, or the ones which are third generation progesterone pills, those are the ones which would prescribe. For example, drospirenone, or I mean the another one that I normally prescribe would be Ginette, which has cyproterone acetate, which does not have any androgenic potential. Flutamide is one which is not actually a ethinyl estradiol combination, but there are many girls who are on flutamide and they are doing well. I mean, they are basically on flutamide for androgenetic alopecia, or female pattern hair loss. So that is one more pill which can be given, though it can cause liver toxicity, and LFTs need to be monitored very, very cautiously. So those are the pills which normally I have experience with. Apart from, of course, this thing, spironolactone. That is another pill which is has got a very good side effect profile and a very good efficacy rate also in patients of cutaneous hyperandrogenism.
Regarding flutamide, Dr. Uday Phadke, what is your opinion about use of flutamide? Should it be used or should not be used?
Should not be used.
Should not be.
I would caution people to use about using flutamide because the liver toxicity is fatal and idiosyncratic. It's very difficult to decide when it occurs, and we have lost patients on flutamide. So I would be very averse to using flutamide as therapy.
So that's what I wanted to ask. There are many patients who I have referred to endocrinologists and they have started them on flutamide. So that's what I wanted to know your experience.
I don't think we should. In the presence of other simpler drugs like spironolactone, cyproteron, finasteride, I would not use flutamide as the first choice of drugs. Certainly not.
Yeah, so we have safer options, so might as well go for safer and effective options rather than going for something which is going to be toxic and fatal. Because even if it happens to one person, for that person it is 100%. So we should try and save that risk for the particular patient. I will take few of the chat box questions because I think we are exceeding time. So one question from Dr. Vinay Kulkarni is there. If a person is walking about 4,000 steps as a part of routine work, is that enough or you have to have additional exercise? I think Maitri is not there, and probably she has told us that 10-minute bouts and 1,000 steps at least three times in a day, that is 3,000 is good enough. Then there is a question regarding the best vegetarian source of protein that you can advise. Varsha.
Best vegetarian source, like if the most of the patients nowadays take eggs also, so eggs is a good quality protein. But then even if egg is not been taken, we can go for milk and milk products. Even paneer is a good source.
One question from again Dr. Vinay Kulkarni. He is talking about a pap smear as a screening test. We were talking about the risk of cervical cancer and the breast cancer. So for cervical cancer, he is saying that would you suggest HPV testing for these women? And if that is negative, can we assure that relatively very low risk of a cervical cancer rather than going in for a pap smear? Ashwini.
This HPV DNA test is just an extension of a pap smear, I would say. It is done in the similar way how we do the pap smear. The validity of pap smear is for 1 year, where the validity of the HPV DNA test is for 3 years. So if the HPV DNA test is negative, it does assure that there is a very low risk, but that doesn't avoid the follow-up. So if any women, any girl, any lady who is around 40, 40 plus or in a perimenopausal age, and if you are starting on combined oral contraceptive pill, the follow-up with the HPV DNA testing is required, or with the pap smear is required, or at least she should be explained about the risk and the initial symptoms like postcoital bleeding. What happens is, why the fear is always there, that when a lady is on oral contraceptive pill, that tends to increase the vascularity in the cervical region. So there is always a natural increased vascularity for someone who is on oral contraceptive pill in the cervical region, and somebody who is prone for a cervical cancer also will come up with a symptom of postcoital bleeding, and then that creates the fear. So that's why HPV DNA test is definitely a better test than pap smear, but not advised because not done at many places. It's done in metro cities like Pune, Mumbai, but not in the periphery. So it becomes very easy to advise pap smear for the patient. So as far as the follow-up is concerned, the bottom line is patient has to do a follow-up if she is on OCP.
Yeah. And follow up, even if like patient is not on OCP and cutaneous hyperandrogenism, a follow up and a long term follow up is what is most important for all these patients. So that we have to emphasize and counsel right in the first visit. There is a question from Neena Madnani. Madam Vasudha, if you know, you can answer this. What do you mean by a facial plethora? I don't know what it is. Do you know?
Plethora is when there is erythema. I would say there is a lot of suffusion of the face. That is what I would think is the meaning of facial plethora. I don't know how it is flushing basically.
You're right, actually. Plethora, facial plethora is a use to describe the typical features of Cushing's, where it looks flushed and reddish and swollen. So the facial plethora, the moon face, are typical signs, soft signs of Cushing syndrome.
And the similar thing would be seen in anybody who has got hepatic dysfunction, even alcoholic plethora. Even it's the same thing that you get in many of these conditions because of vasodilatation. Basic thing that is there is vasodilatation, either due to steroids, topical or systemic. Even some PCOS patients might be having that same kind of thing. So any of these
it's not like erythema of it's not something like erythema of rosacea. So it's a different entity in itself, and it can be an early sign of Cushing syndrome, right? The question from Mutalik sir, he wants to know, just looking at the clinical signs, is it appropriate to give a trial with cyproterone plus estrogen plus metformin? If yes, how long? I think, and of course with the diet and exercise, if he wants to know. So this, I think we have already answered. So it is most of the times clinical diagnosis, and we do it if in treatment resistant cases rather than as a first line. Patwardhan sir wants to know about finasteride dosage. Like we dermatologists, as you said, we are with a lower dose, and we give a 1 milligram dose of finasteride to treat female pattern hair loss. So is it 1 milligram or 5 milligram? And what is the ideal one? Dr. Uday Phadke, do you want to answer this?
So we can use any dose from 0.5 to 5 milligrams. What we typically do is start with 5, and as patients improve, we try and get them down to 2.5, 1 milligram also. And it's individual. Some people do respond to 1 milligram also. Some people do require 5 milligrams. So we start with 5 and try and get it down to a smaller dose.
And what is your take on oral dutasteride? Do you use it in your patients' female pattern hair loss, or you are mainly on finasteride only?
I haven't honestly used much of dutasteride.
Okay. Anybody
and
wants
there is very little literature also on use of dutasteride in these types of disorders as compared to say finasteride or spironolactone.
Yeah, because as a dermatologist, we do use it in male pattern, the dutasteride, and few of them are using it even in female pattern. Vasudha, do you have any experience of dutasteride in female pattern hair loss?
No, ma'am. I've used only finasteride. I've just started using topical dutasteride. Haven't used systemic or oral dutasteride yet, at least in females.
Yeah. One more question from Utalik sir, pattern alopecia and hirsutism combination. So would you prescribe minoxidil to these patients, or you will not use minoxidil? A patient who has
already,
both.
pardon? Yeah. So
Patient has both.
I said there is hirsutism, there are chances that the patient might get additional hair growth elsewhere as well, because the minoxidil sometimes seeps. Though of course hirsutism is different, it is androgen dependent, and the minoxidil causes hypertrichosis as such. It wouldn't cause hirsutism. It would not promote hirsutism as such. But yes, it would cause hair growth elsewhere. That is quite possible. There are patients who have systemic absorption of minoxidil after topical use, and they have got unwanted hair growth over non-androgen dependent sites. So that likelihood is always there.
So would using a lower concentration, like say 2%, would be more ideal for these patients if at all you want to use it? Between 2 and 5, the minoxidil.
Yeah, 2%, yes, 2% would do. But of course, if the patient doesn't respond, we know most of these women do not respond to 2%. We have to step it up to either 3 or 5%. And we have to tell them to be very, very careful and, minimize the, maybe just once a day should be enough rather than twice a day. That would sometimes compromise the efficacy. So, but there is no option. Like, you just have to ask them to use it. There's no other way out.
One quick question about the treatment failures. Like every time it is not a rosy picture. So you treat your patients with all the ideal machines, all the ideal parameters, and you treat them adequately, and still the response is poor or inadequate. And at the end of 6 sessions, the girl is still unhappy. So do you stop treating these patients and tell them that probably you're not likely to respond, and you go with the temporary methods of epilation, or you keep trying the treatment for indefinite period of time? So what is the strategy? What should we do?
This question is for me.
Yeah, for you, Vasudha.
Yeah, of course, non-responders.
Non-responders is a challenge, isn't it?
Yeah. So non-responders, of course, if they are normoandrogenic, then and despite that, as I earlier mentioned, we would think them to be having cutaneous hyperandrogenism and start them on anti-androgens to augment the response to lasers. And some of them, if they do not respond despite that, then we would, so there are many patients whom we've, given 12 sittings or 15 sittings, and despite this and systemic anti-androgens, they don't respond. Then in that case, we have to tell them that they have to go on with other, maybe cheaper ways of going ahead with hair reduction. And another thing is topical eflornithine hydrochloride. We can give that along with lasers and anti-androgens. So that would sort of prolong the hair-free interval. So if these patients have hair growth or require sessions once in a month or once in 2 months, then along with topical eflornithine, that hair-free interval would increase and maybe 2 or 3 months. So that would reduce the total cost of treatment and augment the efficacy as well. So that is what we do with non-responders or poor responders.
Anything else you want to add, Dr. Phadke, for these non-responders? No. Topically, eflornithine, Vasudha, I want to ask you, like, is it really cost effective? Because it's just a 5-gram tube costing 500 plus rupees, and a terminal hair and 5 fluornithine, this thing, it really doesn't make any sense, because it is not at all cost effective, because it doesn't work. Because in that money, we can give one laser session to this patient. So do you really think that
small
it is
areas Yeah, only over small areas, and that too, as I said, if and only if the female is totally disgusted and disappointed with the laser treatment, that is the only thing that we can add if she can afford it. Otherwise, then, as I mentioned earlier, it is not something that we would give initially at the beginning of the laser treatment. Because
affordability is one part, but effectivity also, like, do you really think that it is effective for terminal hair? The remaining hair are also terminal.
No, it does not reduce, ma'am. It does not. It's not like a hair removal cream. What needs to be understood is most people, they think it is a hair removal cream, so they apply it over the hair. It's not that way. We have to remove the hair with whatever depilatory or epilatory methods. We have to remove the hair from the root, and then to reduce or rather increase the hair-free interval, we can use eflornithine. It's not like something that is to be applied on the hairy area and remove hair. That has to be understood. There are many dermatologists and maybe general practitioners who feel that it is something that is to be applied over the hair and the hair will get rid of. It's not that way. So it will
It
only
is the
reduce
hair-free
the growth of
interval
hair.
it can increase, yeah.
Yeah, we can only increase the hair-free interval, nothing more than that.
Yeah, so this scenario, I think we had discussed the high DHEAS and prolactin slightly high, in which Dr. Phadke said you should not worry about a slightly abnormal prolactin level and don't over investigate these patients. So I think I will not repeat. And the message that we wanted to give is that every time it is excess androgen, it is not from ovaries, it can be from adrenals. And Dr. Phadke has already told us that towards the menopausal age group, this cost should be kept in mind and should be ruled out. So, and the DHEAS is the investigation to know whether it is from the adrenal source or not. Am I right, Dr. Phadke?
Yes, I mean, partly yes. We don't do DHEAS routinely. That's the only thing. If you want to investigate for CH, 17 OHP could be a better marker.
Better markers. So 17 OHP and maybe DHEAS if at all, and sonography also, right? So these are the three basic tests which we can add in these patients. And now last slide regarding the use of nutraceuticals. So there are a lot of papers and lot of reports and lot of talk going on about use of myoinositol, alpha lipoic acid, N-acetylcysteine, folic acid. So my question is, do we really need them? Or can we supplement them in the diet? If at all you give them, is it cost effective? Because most of them are really very costly. And I do see a lot of gynecologists using myoinositol as a part of their prescription. So regarding myoinositol, I want to know from Dr. Ashwini, and rest of the things I think Dr. Varsha can comment on.
Myoinositol for the indications where the contraceptive pills are used, like for the acne and hirsutism, I have never used as an insulin sensitizer. Myoinositol has a very restricted role in fertility related patients. So I don't prescribe myoinositol at all to these patients. There is a group of patients where we do use it in PCOD with fertility, but not for these patients.
Ma'am, regarding myoinositol, it is basically a vitamin B group member, and usually it is produced in the body. But there are few studies which have shown that in PCOS patient we have less of myoinositol. So that can, that can be the basis of giving it like as a supplement. But definitely the cost factor limits the use. And secondly, when we are giving a lot of when we are reducing on carbohydrates, we need to give supplements of iron, calcium, and vitamin B group, because then by like decreasing the calories, the patient can land up into vitamin B deficiency, which can be in the sort of stomatitis or aphthous ulcers can be seen. So definitely we can supplement with the required supplements rather than going for myoinositol.
Okay, and regarding folic acid?
The whole when you give the combination, it has low levels of folic acid also, like in it.
Okay,
And
so
can I
now,
just ask one question?
Yeah,
Vitamin D
please.
deficiency. Yeah, ma'am. There are a lot of reports which say that vitamin D deficiency
vitamin
has
D.
been associated with PCOS. So I just would like to know from Phadke sir as well as Dr. Ashwini whether it makes sense to supplement vitamin D in patients of PCOS, or do we need to subject them to routine vitamin D level testing and then start them on vitamin D supplementation? What is your take on this?
So vitamin D has been kind of associated with everything in this world, from diabetes to PCOD to cancers, immunological protection, and a large-scale randomized trial has failed to show any benefit except in increasing vitamin D levels, preventing falls, and reducing bone pains. So all this is unproven. You don't need to do a vitamin D level to just supplement vitamin D level, because statistically 93% of Indians are vitamin D deficient. You can safely give standard doses of vitamin D. That's number one. One caution about, see, a lot of people give folic acid blindly without, especially to people who are going to conceive. Now remember that if you give large amounts of folic acid, and 5 milligrams a day is a huge dose. The normal requirement of folic acid is between 50 to 150 micrograms per day, and 5 mg is like 5,000. If you give large doses of folic acid in the presence of B12 deficiency, it seriously worsens insulin resistance, which Indian women already are. So be a little careful about the use of folic acid and for what we are giving. Nutraceuticals are available over the counter only in India and in no other country, practically no other developed country. The use of myoinositol, acetylcysteine, ALA outside of controlled trials is not recommended. The ALA also has a number of other vague side effects, including precipitation of very severe hypoglycemia looking like an insulinoma. So unless these drugs are really proven to be beneficial in randomized controlled trials, it's best to avoid casual use of such drugs. And these are mostly sold because medical reps and come and tell us some weird biochemistry, which I think you should throw out of the window.
So all practical purposes, the nutraceuticals, I would say, should not be used as a supplementary treatment in your practice, because it is something like a homeopathic or Ayurvedic medicine. You don't know what is the benefit you are giving it, but it is definitely associated with some of the serious side effects, as you mentioned about hyperglycemia and all those things. So better not to give if you don't know the real effect of these medicines. That is the message regarding this nutraceuticals, and they are pretty much costly. So as it is the pill and the pill burden for these patients is also quite high. So why unnecessarily add something which is not going to be useful? So that is the final message about all these nutraceuticals that are available in the market. So with this, I think we conclude this great panel discussion. The topic is so vast, so it is going to be never ending. So even if we keep one whole day, we will not stop discussing this PCOS and its implications. But we today really had a nice interaction. There were a lot of inputs, and especially how to investigate, how to do minimum investigations, what treatment, how everything is, I think, very clear to us after these inputs from all our panelists. So it was really a nice interaction with all of you. I thank you all from my bottom of my heart for being part of this panel. And one final thing, like each one of you, can you just summarize what is the final message that you want to give to the delegates on this panel? So I will start with Dr. Phadke, Dr. Ashwini, then Vasudha and Varsha.
My only message is be rational. That's all.
Yes.
And scientific. Period.
Yeah. Ashwini?
My message would be, I sometimes feel counseling is lacking before writing any prescription of oral contraceptive pill, counseling and insist for the follow-up so that all the possible reactions can be avoided. So counseling plays a very important role.
Yes. Vasudha?
I would say history, clinical examination, and minimal investigations. So that, I think, history and clinical examination, there is no shortcut. Most of us, sometimes when it's a busy practice, we are faced with a lot of patients. We tend to, like, there's a shortcut on history. We don't even bother to ask history. We just write a list of investigations. So I think that has to be curtailed and curbed. So that would be my take-home message.
And
detailed
Varsha?
clinical examination.
Yes,
Okay,
so it's more of a clinical, old time teaching, like go by clinical and not by reports, that we re-emphasize again today.
And treat the
Varsha?
patient, not the reports. I think that
Yes,
would be the
exactly.
bottom line for me.
Yeah. Varsha, do you want to add something?
Ma'am, to sum up, I would say in all cases, being natural is more important. So going for natural foods, that is less of refined foods, and taking a high protein diet. So the protein should be a part of each and every meal of your day, along with lots of fruits and vegetables.
Yes. So thank you very much once again, all of you, for being part of this panel. And thank you for those 3 excellent presentations by Dr. Uday Phadke, Dr. Ashwini, and Dr. Maitreyi. Unfortunately, we could not have Maitreyi today. If she was here, we would have had more discussion on the exercise part of it because she specializes in that. But nevertheless, we will call her once more especially for the exercise and PCOD. So with this, I conclude this session, and I think we have mostly covered all the questions from the chat box. Pradyumna, I want to know, is anything remaining from the chat box which you think that we need to address here?
No, madam. Everything is covered.
Everything is covered. So now I hand it over back to Purva for vote of thanks. Over to you, Purva.
Thank you, ma'am. As we come to the end of today's CME, I would like to once again thank our speakers for today, Dr. Ashwini Margare, Maitreyi Bokhil, and Dr. Uday Phadke, for agreeing to join us today and for their excellent talks and for generously sharing their expertise with us through their talks and the panel discussion. I also thank Dr. Dhanashri Bhide, Dr. Vasudha Belgamkar, and Dr. Varsha Sidwadkar for their valuable contribution in the panel discussion. I also thank INTAS for providing the technical support today. Last but not the least, I thank you all for taking the time to attend this event on a Sunday morning. With this, we come to a close. Ladies and gentlemen, have a great day ahead. Thank you.
Purva?
Yes, ma'am.
ते जरा ह्याचा अनाउन्स कर ना feedback form.
Yes, before we part, let me again remind you to fill in the feedback form at the end of at the end of the CME. The link is available on the WhatsApp group, and this is essential for you to avail your single MMC point.
Patwardhan sir, do you want to say something? प्रद्युम्न पटवर्धन सरांना काही बोलायचंय का?
नाही मॅडम.
मग काय एंड करायचं मीटिंग?
Oh, yes, madam.
Should we take one final photograph if everyone is there? And मला काही दिसतच नाही. येतोयस का? So should we leave the meeting now?
Yes, ma'am.
Yeah. So thank you very much, Varsha, Vasudha.
Thank you, ma'am.
Yeah, Dr. Uday Phadke, for your valuable contribution, and thank you all the delegates for being present on this Sunday morning. And I also would like to thank Team INTAS for their support for this CME, and as well as the technical team, because today it was really a village-free kind of event. So thank you so much, everyone.
Thank you, ma'am.
Thank you.
Thank you so much, ma'am, for giving opportunity. Thank you.
Thank you.
Thank you, ma'am.
Bye-bye.